morning.
Yeah, no. Okay, here where this is. 1 minute.
I'm just going to go text them to send them in real quick. Ladies and gentlemen, distinguished guests, and esteemed researchers, good morning and welcome to the annual Avalon University School of Medicine Research Symposium organized by the American Medical Student Association, popularly known as AMSA. My name is Anushka Lagati and I'm the AMSA president for Avalon chapter.
And I am Hazim Musa, the SGA president. To ensure a smooth and enjoyable experience, please remember to turn off or silence your mobile phones during the sessions. We also encourage you to participate in the discussions and ask questions to make the most out of this valuable opportunity. If you would like to ask any questions, please raise your hand and the mic will get to you in no time.
Today is the day of celebration, discovery, and collaboration as we come together to showcase the remarkable achievements of our medical research community. This symposium is a testament to the dedicated and hardworking, talented researchers, doctors, students, professors, who are all driven by their passion for advancing the frontiers of medicine. As the AMSA Avalon chapter, we take immense pride in fostering an environment that encourages curiosity, creativity, and excellence in medical research. This symposium is a culmination of our collective efforts as we strive to build a platform for exchanging knowledge, sharing insights, and inspiring one another to push the boundaries of what is possible in the field of medicine.
To all our researchers, I extend my heartfelt congratulations on reaching this stage. Your dedication to improve the life of patients and making a lasting impact on healthcare has not gone unnoticed. Today, we celebrate your achievements and we eagerly anticipate the ripple effects your work will have on the medical community and beyond. The theme of today's conference and research is emerging topics of research following the COVID-19 pandemic. This theme is a testament to the collective effort and commitment of researchers and medical professionals worldwide to address the challenges and opportunities that lie ahead. In these uncertain times, research remains at the forefront, guiding us towards a brighter future. Throughout this event, we will explore how our collaborative endeavors can shape the world and drive positive change following the COVID-19 pandemic.
I encourage all the attendees to actively participate in the discussions and engage with the speakers, ask thoughtful questions, share your insights, and explore potential collaborations. The beauty of research lies not only in the discoveries themselves, but in the collaborative journey that leads us there. Without further ado, I'm thrilled to announce our opening speaker for the day, Dr. Serveling Kelly. Dr. Kelly completed his medical studies in the Netherlands, and after working shortly as a family physician, he went on to supervise and coordinate the vaccination administration and campaign combined with preventive mother and child health at the Public Health Department of Curacao from 1986 to 1987.
In the following years, he further specialized in social medicine in the Netherlands, including certain courses taken at Johns Hopkins School of Public Health. He went on to work as a scientific co-worker specialized in cardiovascular, nutrition, and infectious disease epidemiology, as well as biostatistic methodology at the Netherlands Institute of Public Health. He then completed his PhD in epidemiology in 1995. Dr. Kelly returned to Curacao in the following 27 years to work in the field of public health. His positions ranged from the manager of the Staff Bureau of Planning, managing epidemiology and biostatistics at the St. Elizabeth Hospital, to being the head of the Curacao Public Health Service. Additionally, he worked as the director of the Curacao Health Sector and currently works as the Inspector General of Health in Curacao. He has been teaching since 2007 in different academic institutions and has since published several articles on cardiovascular, nutritional, and infectious disease epidemiology.
Following opening address, Dr. Kelly will commence with the first keynote speech for the day. He will be discussing long COVID state of art and latest developments. Please join me in welcoming Dr. Kelly to the stage.
It's great, very gentle. Good morning, everybody. To the welcome to the Dean of School, Dr. Arja, Dean of Basic Sciences, Dr. Bala, and all other faculty present, and all students present. This is your big day. This is one of your big days. As the I'm speaking now as the from the government, actually, and as a government, we're always very proud that when research is being done, because research generates a lot of knowledge from for the community, from the community to understand the community better. So in this sense, it is very welcome that Avalon is embarked now more and more in research, and surely given the tight cooperation that's going on and being set up with the local institutions. So the community will benefit a lot from what's coming from Avalon. Furthermore, as a country, it is important to have a school that is engaged seriously and intensively in research. And in that way, it is important to see that Avalon has gone a very far way, and I think it's very important to congratulate Professor Lambo with his efforts, always non-stopping effort to getting things done with excellent results, always. I think it was first year in 2019, just before the pandemic, so that was extremely great. And also, it is important that the school has been stimulated by Dr. Arja and Dr. Bala, always in every sense of word, to do this. So from the part of government, it's very grateful, and please consider this day opened. A few words as the Associate Dean of Research. I think this is a great day, and again, with a lot of congratulations to Professor Lambo for his efforts. He's the central figure in setting this up, but also carrying all efforts and all extra time and everything, and the results are always extremely great. So I would like to give a hand to Professor Lambo for his work. And we're entering now an era of intensification of research, and it will become very, very visible this coming semester, that the amount of research is going to be intensified. The environment of research is going to be made much stronger, and because everything happens at its time. So we have come where we are, and then it is important to keep going where we are going. So, and as a student, you are actually the most important asset in research, and the faculty will be there to assist you. If you have any questions, sometimes it might be that it is because you do not know everything yet, but experience learns that sometimes when you have questions, there might be questions that have been answered yet. So always take into account those answers, search them out, and maybe they're the research that has been born in this way. So keep it and with you, and if you have any questions, be there. We will be there for you. So that's what I wanted to say as the Associate Dean of Research. So we will be going on, and coming semester you will be experiencing much and much more. Okay. The first keynote I'm talking about is about the long COVID. And long COVID, it's got a lot of names. And if you look at the second slides, actually the official name that was proposed, that was the post-acute sequelae of severe acute respiratory syndrome coronavirus 2, SARS-CoV-2. Actually, sequelae, as you know, that stands for the long-term consequences, the remaining symptoms and signs. And that is actually regarding COVID, it keeps going the way COVID has been going. COVID, as you know, started which seemingly was a viral pneumonia without any other explanations. That's actually how it started. But you know that during the course of COVID, it started presenting itself in other way. We all remind that when Delta variant was introduced, actually the anosmia, the lack of smell, the loss of smell and taste was something that suddenly appeared much more often than it used to be. After that, we had a situation that COVID would present, in most extreme cases, as a rash. So we have seen actually the broadest spectrum of presentation we've always seen. And this virus has been so ever-changing, and with every change, any virus that actually strain that was staying in circulation actually became more contagious. So it adapted itself to the circumstances by getting a better adherence to the epithelial cells, and to getting it an easier way of entrance into the human body. And with that broad spectrum, and when we thought it was over, the first ideas were that because people had been laying long time on intensive care unit, and that they had to rebuild their muscles again, and that everything had to be started again, that was actually one of the most serious things. Then the news started coming about people having chronic fatigue, and after that, the lack of concentration and actually brain fog started to come forward. But after that, people started to see much more things. And and you see that when things go in that way, people give a lot of names. So we have the official name, actually, which is the post-COVID condition. That is the name that WHO has denominated for this situation. But other people have given it long-haul COVID as a name and different other names. We don't know yet the exact scale of this condition, because more and more it's coming up front. And when we go through the clinical presentation, you will notice why. Because it's very difficult to distinguish it from already known conditions that we already struggle with to their causes. So it's very difficult. So the scale, we're not sure, but if you look at the second slides, what is estimated that 100 million people worldwide are affected by it, and that, but at least that's in the USA, that approximately 4 million people are not able to work. And these are referring to the people that are not able to work. But you have people that are able to work, but simply they cannot produce what they used to produce. If you have a lack of concentration, if you have a chronic fatigue, it's very difficult to keep providing the same production as you will do and you used to do. And the economical damage is enormous. That's the thing. But we've seen it, and I've seen it close by here from different instances, and also, like for example in reports in Holland, it was a big issue that people were thought of as being trying to exploit their post-COVID condition for not returning to work by claiming it's chronic fatigue, I cannot work, and then everybody says, yes, but now, right now, if you are 6 months at home and it's over, you should be able to work. And then people started to work, but then halfway to work, they would go home again simply because they could not sustain a total day of work. So the stigmatization then started that people do not want to work. And that's something that's not something new. We have seen it before in the chronic fatigue syndrome, chronic fibromyalgia, where people are actually mentally and physically disabilitated by the fatigue, and the outside world is not understanding what's going on. And this is in terms of those patients, this is terrible, because there is nothing more terrible when you have a condition and nobody understands your condition, but on the other hand, you're being stigmatized as being a person simply that tries to misuse the situation. And up to now, as is the case with COVID, we do not have an adequate treatment. So what are the risk factors? If you are looking at the risk factors for the post-COVID condition, actually, they are the risk factors that we have seen before, actually in causing a more serious and form of COVID, and with a more negative outcome in COVID. So you see again obesity coming up in front, diabetes mellitus type 2, asthma, severe COVID-19 requiring hospitalization, and pre-existing depression, hypothyroidism, and the more serious the symptoms are during the disease, the more situation that might appear later. So you see dyspnea, myalgia, anosmia, headache. People at high age also, just like in the acute COVID phase, they are more at risk at getting long COVID. And the higher the SARS viral load is during the disease, the more it is. And the idea behind this, that the higher the viral load, the more actually structural damage has been made to different organs, and that therefore the consequences are more serious. And that was something that was observed even when patients were sick after a few weeks. If you had a high viral load, if that would drop after a few weeks, 3 to 4 weeks, even then the damage would be stay there, and with several persons on IC units having actually being no longer positive for COVID itself, but still suffering the consequences. And we see all those situations, they appeared in the beginning to be related to the ACE receptors on the cells, because this is the adherence spot for the SARS virus. But if you look at the evidence which is now amounting, it's much more than that. So if you look at some of the risk factors a little bit closer on the next slide, you will see that actually age is a factor that plays a role, especially when people are over 70 years old. They have, you see, a 21.9% compared to 9.9% in 18 to 49 years old people. Women are more at risk than men, but that is before the age of 70. After the age of 70, actually, they become the same. Now, in ethnicity, you see the same manifestation that we see sometimes in other diseases, that in a Black, Asian, and minority community, at least that is what has been found in the UK, you see a higher prevalence than in Caucasian patients. And we've seen that also having to do with the ACE receptor constitution. And the genetic predisposition, actually, and there is an area where there's not so much evidence about, but it's have been proposed that the Neanderthaler gene actually, and this has to do with the evolution in men, actually in chromosome 3, actually that gives us more aggravating situation, while if it is on chromosome 12, it gives protection. And so these are the main things. And where you have immunodeficiency and immunity dysregulation, when it is present, you have much higher prevalence for long COVID than when it's not the case, when people have a normal immune situation. So we're talking about autoimmune diseases, we're talking about immune dysregulation, for example, in cancer patients. Patients that are for other reasons are being treated by reducing the competence, and as most of the cases they become more susceptible, but this time it's also for the long COVID they become more susceptible. So the question is, what could be the cause of all this? As you know, in epidemiology we always think, okay, everything can happen, but what is the explanation? What is the biological plausibility? Because once you know the biological plausibility, you can think of mechanisms in order to bring forward solutions. And just like in long COVID, just like COVID itself, the spectrum was very broad. In the biological plausible mechanisms, a lot has presented itself, but on all types of areas. So again, we see the same what's happening in COVID, also in long COVID, and the mechanisms proposed that we have a very broad scale of possibilities. And probably we have not seen the end yet. So this is an ongoing process. We're now actually 3 years after start of the pandemic. I think in December we're going to enter the 4th year after the start of the pandemic, and still we do not know the total picture. So in the proposed biological plausible mechanisms, the most plausible one and most often thought about, that is the persistence of the virus or its components in different organ systems. We're talking about the brain, sinus, adrenals, kidneys, guts, lymph nodes, so spleen and lungs and other different organ systems where it persists. And this has been often associated with the viral load and the speed of spread of the virus. So, and this is one of the things. So you might have a direct viral effect that the virus directly attacks the systems within the cell, especially in mitochondria. And another thing is that you might have inflammation, and inflammation by itself has its own consequences that keep going on for a time. So it is a combination of things. And as we know, whenever you have an immune response to everything, the immune response itself generates damage. The immune response is meant to protect the organism, but still at the same time, those effects can be causing damage. Some cases with autoimmunity. And one of the most dangerous parts, that is the occurrence of microclots resistant to fibrinolysis. And so when the coagulation pathway actually fails, is not able to resolve coagulation, then of course the situation becomes very serious. The central nervous system effects, they are actually considered to be the way the inflammation of the nerve cells and other structures inside the brain. So it has an anatomical substrate, and that makes it, of course, very serious. the reactivation of other viruses also has been a thing. Now, so the question is, if you look at a clinical presentation, what would you like to do? Of course, we all would like to have a very clear, concise clinical picture that you can get a clear indication of what is the extra diagnostics that you have to do in order to distinguish the long COVID from other conditions. Now, again, it can present itself in many ways. The fatigue, that is the most recognized and most persisting condition that presents itself. But here also, like in other presentations of the clinical pictures, you have to distinguish and you have to eliminate other causes, that could be the explanation. The anosmia, dysgeusia, these are actually, they have been observed to last for shorter time or longer time, but usually after longer or shorter amount of time, it tends to restore itself. The persistent dyspnea, and it's, of course, it has to do with the together with the fatigue, and that is something that is very debilitating, and this can persist for very long. The palpitations, and also what you see that people can present themselves even later with myocarditis, and making it a very dangerous situation. And even when you have a normal situation, people might be responding disproportionately with tachycardia on very light amount of exercises. So the cardiovascular component is something that keeps going on, and the memory impairment is something that is also on very long time. What is less expected, these are the neuropsychiatric psychiatric presentations in insomnia, daytime sleepiness, anxiety, and the post-traumatic stress disorder, and the elevated suicide risk. And one of the things is the actually alarming, that is the psychotic homicides that actually are presenting themselves. So actually it is very concerning what can present itself in the aftermath of COVID. And some of them are different, very difficult to distinguish from effects of the lockdown itself, because we've seen that the lockdown produced a lot of anxiety, a lot of depression, an increase in the suicide rates, but still you see that this can be on as an effect of COVID itself. So what you see in summary, again, is a very broad presentation in an extreme way. And if you see at the next slide is not meant to be explained. It's only meant to give you an idea. And this is not the usual picture that you see when you try to find a biological explanation for what's going on in a disease. This is not what we usually get, and this is still not a complete picture. So there is a lot of work to do, a lot of way to go, and of course it is important for you as a student at this moment to grow with this situation, because one day or another you will be confronted with patients where you have to find out what's going on, and then it's about the research that you will need to know what's going on, and you have to keep up with this, because this is a puzzle probably that piece by piece will be resolved. It will be made more clear, but it will take its time. So you have to evolve, because irrespective of the stage where this research irrespective of that stage, the patients will present themselves. So probably the patients will not, and if you are lucky, you will be in a stage where it has been already resolved. But as you know, medicine is an evolving science, and you don't know when the patients will present themselves, but you have to find a solution. We've come a long way in the sense that we didn't have CT scans, we didn't have MRIs, the patients were there. And now this is, for this, it is exactly the same. Now, I will, so the conclusion is actually, what's next? Answer, we don't know. Let's just wait and see and try to do as much research as possible to find out what's going there. Thank you for the time, and if there are any questions, I'll be happy to take. Sure. Any questions? Being said, either it was very clear or it was very confusing. So, okay, now thank you. Okay.
Thank you very much, Dr. Kelly. Good morning once again to everyone in attendance today. My name is Justine. I'm an MD3 student here at Avalon, and I will be one of your hosts for today's events.
And my name is Zaira. I'm also an MD3 student here at Avalon, and I'll be one of your hosts today as well.
My name is Ibrahim, and I'll be your third host for today's event. Before we dive into the main program, I would like to take a moment to express our heartfelt gratitude to Avalon's research and ethics community, as well as the AMSA and SGA teams for putting together this amazing event. Their unwavering support has made this conference possible, and we recognize the vital role they play in advancing research and promoting knowledge exchange. Please give them a round of applause.
Our next keynote speaker for this morning is Dr. Salim Mohammed. Dr. Mohammed is a highly experienced and renowned pulmonologist based in Chandler, Arizona. With over 35 years of experience in the medical field, he is a distinguished expert in diagnosing and treating conditions of the lungs and respiratory system. Dr. Salim obtained his medical degree from King Edward Medical University in Pakistan and has completed his medical residency in internal medicine at Cook County Hospital.
Overall, Dr. Mohammed's dedication to improving the lives of those he serves, his extensive medical experience, and his contributions to the field of pulmonology makes him a highly respected and sought-after pulmonologist. Patients and peers alike recognize him as a beacon of hope and healing, and his impact on the field of pulmonology continues to inspire and transform lives for the better. Please give him a warm welcome.
Good morning. Can you all hear me? Am I visible? And can you hear me? Need a feedback?
Yes, Dr. Salim.
The volume good?
We can hear you.
Okay, good. So, good morning. It's earlier here in Arizona than it is at Avalon, but hopefully we can carry out this interesting conversation here. I feel this is very close to my heart because I see this every day. And because, as you know, cancer is on the rise in the United States and rest of the world. So if we can catch it sooner, we can do something about it. If we can't, unfortunately, mostly, we catch it when it's already spread, stage 3, stage 4, and then the 5-year prognosis for these patients is, it's like 7%, very low. So there has to be a lot of effort in trying to find the lung cancer sooner than later, because that means life, prolonging life, quality of life for these individuals. And why is it so high? I think you know that we still have not achieved an awareness about cigarette smoking and its causes. Obviously, there's genetic factors, there's other reasons. But unfortunately, the main cause still remains. I was actually traveling, and so I was actually in Istanbul for some work I had to do, and a lot of people there were smoking. It was especially women. It's unfortunate, but the awareness has it needs to be improved, and we need to have symposium on cigarette cessation, which is basically the cause. Unfortunately, humans will be humans, and vaping is very common in the United States. People make it's a commercial product, so you've got ads with actors coming on, smoking, vaping, and encouraging the youth to do the same. And unfortunately, it's the advertisements are very powerful. The images are very powerful. You have this group of young people who are trying to find themselves, basically, and there's a lot of temptation. You know, there's a saying in English that I can resist anything but temptation. So the temptation's out there, and a lot of people fall prey to this temptation. And it's all the ads, it's mind control, it's peer pressure, and the false sort of thought that it's not dangerous, which is totally misfounded. As we actually see people with vaping in the ICU because of pneumonitis, so it's as bad, or I would say even worse than cigarette smoking. Anyway, let's get back to the topic at hand. The solitary pulmonary nodule, you're going to see this a lot, and don't ignore it, because especially in the United States, there have been a lot of lawsuits because people ignore these little, oh, this is just a granuloma. Yes, it may be a granuloma, but it may be something more ominous. So it's really good to investigate every nodule or to follow it to make sure that it's not growing, and that's the main point of it. So it's a round or oval opacity, smaller than 3 centimeters. And the reason they say 3 centimeters because then it becomes a mass. Then you start calling it a mass rather than a nodule. That's the cutoff. It's surrounded by pulmonary parenchyma and is not associated with the lymphadenopathy, atelectasis, or pneumonia, because then obviously it might be a part of those things. It might be a part of the atelectasis or pneumonia, and then it's going to get better. It's treatable. So let's go on to the next slide. Let's go on to the next slide. So this is the differential diagnosis. What you're really afraid of, the malignancies, carcinoma, lymphoma, lymphoproliferative diseases, solitary metastatic neoplasm, melanoma. And by the way, melanoma is on the rise too because of the global warming. There's more UV rays. And if people are not protective, even from younger age, even from, when they're kids, there's an association of melanoma. It's a terrible disease. Just anecdotally, one of my pathologists, I was in Texas then, he got melanoma, and it didn't end up well at all, because when they diagnosed it, it was already metastatic. So sunscreen should be used very early. Bronchial carcinoid, and they're called the iceberg tumors. They sometimes, when we do bronchoscopies, they show up just as a little, like a little bump, on the side of the mucous membrane, but then they're icebergs, so there's a lot under that. And the treatment is not the best, but a resection is the best, so we try to get it resected if possible. And then sarcomas. Next slide, please. So the benign hematomas, endometriomas, mesenchymal tumors, they're easier to deal with, and they're benign, of course. Then you have the infective causes. A lot of these nodules are infective. In Arizona, we have fungal disease called coccidioidomycosis. I'm sure you've studied it, but this is the epicenter, as well as California and the San Joaquin area, the valley. They call it San Joaquin fever. So we have a lot of that, and that presents as nodules. So our usual differential diagnosis is this malignancy, or is this coccidioidomycosis, or we call it valley fever here for short. So granuloma, mycotomas, aspergilloma, echinococcus, we don't see that here. Focal ground pneumonia and lung abscess. Next slide, please. So the inflammatory rheumatoid nodules, and we see those pretty much, a lot of rheumatoid arthritis here, especially in adults, some in kids, Still's disease. Sarcoidosis, we see that usually the Afro-American or Mediterranean population, but sometimes I do see it in other races. Wagner's granulomatosis, we see that, not too uncommon, see it now and then. Very important to differentiate that from other benign nodules, because it can involve the kidneys, as you know, and so renal failure, so it has to be diagnosed early. Next slide, please. And airway and inhalational diseases, mucoid impaction. We see that with people who don't have a good cough reflux, other people. Bronchial atresia, cystic fibrosis, less so here. I was in New York during my fellowship, and I saw more over there, because it's also sort of, it's in some ethnic groups it's more than others. Progressive massive fibrosis, lipoid pneumonia, and vaping actually can also give you lipoid pneumonia, which is popcorn lung use. Vascular lesions, hematoma, infarction. We see a lot of PE, and we see lung infarction in different shapes, sizes. Hampton's hump, you might have read that. Pulmonary artery aneurysm, pulmonary vein varix. So we see these AV fistulas or malformations, septic embolism. We see it less now because people smoke their drugs now, crack or meth. Previously, they used to mainline it a lot, and then we would see a lot of these. So congenital bronchogenic cyst, also congenital, you have the adenoform malformation, intrapulmonary lymph node and sequestration. Next slide, please. Idiopathic amyloidosis, when there's some chronic disease present. Fluid-filled bully, when you have a cavity, let's say from tuberculosis, or more common here from coccidioidomycosis, then it gets infected. You have the fluid-filled and round atelectasis. Next slide. And of course, you have to rule out nipple shadows, which can be done with a lateral, and pleural-based lesions, chest wall lesions, which are outside the lungs, skin nodules. These are easily done with the buttons and stuff, with a lateral view on the X-ray. Benign granuloma and primary bronchogenic carcinomas account for 80% of cases of single pulmonary nodule. Next slide, please. So imaging, chest radiograph, you do the CT scan, and less so the MRI. So we don't use the MRI too much, but there's some recent advances where MRI can help you diagnose what kind of nodule it is. So it helps you with the differential diagnosis. And you get, of course, you have the PET scan. So morphologically, the less than 9 millimeter difficult to appreciate on chest X-ray, but seen on CAT scan. So when you do an X-ray, you can miss it if it's less than 9 millimeters. You can also miss it if it's behind heart, the cardiac shadow, or in line with it. So basically, if you are, suspicious, then you have to do a CAT scan, which would be the way to diagnose that. You can see the size, and you can see how that correlates. That's important. And then you get a better size too if you were to do a CAT scan. So the malignancy rate increases as the size increases. Next slide. So the carcinomas are irregular, lobulated, notched, but 25% of benign can be also lobulated. So it's not a 100%. Benign, round, oval, smooth, scars, area of atelectasis may appear linear or angular. Next slide, please. And location, central tumors, small cell cancer, squamous cell, peripheral adeno, and large cell. Metastases are usually basal and subpleural. Benign lesions are equally distributed throughout the lung. So you can see that you can't be sure 100%. Basically, you have to get a biopsy to be 100%. The edges, malignant, are irregular, spiculated, lobulated. Radial extension of the tumor cells along the lymphatics, small areas of blood vessels, and sometimes called like the comet tail. The comet has a tail. The benign are smooth and sharp. Metastasis and carcinoid tumors have sharp, smooth edges. 21% of well-defined nodules are malignant. So again, you see how there's an overlap. You can't be sure. And this is irregular margins. It's the bronchoalveolar carcinoma. Next slide, please. So you can see the lobulated margins here. Next slide. And this is the corona radiata, which is like the sun rising, corona maligna. Here you can see the spiculated margins of this fine strands, linear, extending outwards due to fibrosis surrounding the tumor, desmoplastic reaction. Next slide. So the pleural tail, and that's the comet tail. They have a thin linear capacity extending from the edge of a long nodule to the pleural surface, again due to scarring, but benign can show it too. So nothing is 100%. It just gives a tip off. That's it. Next slide. So halo sign, ground glass opacity, surrounding nodule, seen in leukemic patients with invasive aspergillosis due to hemorrhage, bronchoalveolar carcinoma, also due to the spread of tumor in the lymph. Wagner's can give you this, tuberculoma. So you can see there's a lot of overlap here. Next slide. So this is how you find the calcification. It could be diffuse, central, laminated, popcorn. Next. Homogeneous, uniform, diffuse, solid. So it could be any type, dense, bullseye, concentric rings, laminated, TB fungal granulomas. Popcorn is, again, you can see it in hematomas, and you can see the calcification right there inside the nodule. Next. And diffuse solid granuloma, you can see it. Concentric target on the other one. Next slide. Popcorn, you can see the popcorn, looks like popcorn. Next slide. In malignancies, you can have dystrophic, diffuse, amorphous, some metas from mucin secreting tumors, central calcification, stippled, eccentric. So you can see that just because the lesion is calcified doesn't mean it's benign. It still could be malignant. Next. Eccentric dense calcification in right lower lobe carcinoid, and amorphous calcification in non-small cells. So you can see it's malignant, both of them, but they got some calcification. So it doesn't rule it out. And then fat, hematomas, lipoid, pneumonia, metastatic liposarcoma, area of fat attenuation and nodule, and that signifies hematomas. Next. Cavitation. So if it's a thin cavity, it's benign, less than 4 millimeters. If it's more than 16, it's likely malignant, and then it's intermediate. So you can't be 100% sure here either, like anything else, but it's just a tip-off. So if it's irregular, likely malignant. So you can see the benign calcification on the left, on the right, it's malignant, it's thicker. Next slide. Pseudocavitation, desmoplastic reaction to the tumor, distorts the airway causing narrowing and or irregularity of the small bronchi in relation to the tumor. And that's pseudocavitation, seen as cystic glandular spaces. Air crescent sign, aspergilloma has that air crescent sign around it like a halo, and blood clot in a cyst, complicated high-dated disease, cancer rising in cyst, Rasmussen's aneurysm, which you know is with TB, right? There's dilatation of the blood vessel next to the TB cavity. So mucus plug and cystic bronchiectasis, pulmonary gangrene, air fluid level, usually seen in benign lesions like lung abscess, infected, cyst or cavity, intracavitary hemorrhage, and cavitary carcinoma. Satellite nodules, small nodules adjacent to larger nodular mass, predictor of benign disease like granulomas. Then you have galaxy signs, satellite nodules, and sarcoidosis. Presence of satellite nodules in lung tumors considered to be locally advanced tumor. So you can't be 100% sure. Feeding vessel signs, small pulmonary artery leading directly to the nodule. It's seen in arteriovenous malformations, the fistulas, hematogenous metastasis and infarcts. Feeding vessel signs, small pulmonary artery leading directly to the nodule. And yeah, let's go to the next slide. Positive bronchus sign of pulmonary lesion that directly abuts, narrows, or includes bronchial lumen is more likely to be malignant. But you can again see it in benign things like tuberculosis, pulmonary infarcts, inflammatory masses. The sign helps in whether transbronchial or transthoracic biopsy helps in histological diagnosis. It does help, but now with the robot, we don't have to worry about it as much, and we can get to any of these nodules with the robot. So this is the positive bronchus sign. It just helps us, and if we see a bronchus next to nodule, it just helps us plan the robot. That means we can get right next to it through that bronchus. And these are techniques with the house field units to see if it's nodule enhancement or if what are the house field units if it's less than 15, more than 15. And this is 95% to 100% sensitivity, specificity, 70 to 90. You can see that none of these is 100%. The only thing which is 100% is a good biopsy. That is 100%. You've got to know what it is. Everything else you're not sure. This is they do the 15 minutes delay on the dye and see what the wash-in was and the washout. So basically they're trying to determine if it's benign or malignant. Next slide. So the vascular supply of most malignant pulmonary nodules is from the bronchial arterial system. Washout in the malignant nodules takes place via the bronchial veins. In the washout phase from the interstitial space, a near absence or substantial reduction of lymphatic flow is noted in malignant nodules. The retarded flow in the intravascular and interstitial spaces accounts for the retention of contrast medium in malignant nodules. So you can see they're trying to find out if it's malignant or if it's benign, but it's never 100%. Remember that. In benign nodules, the outflow of contrast through the intravascular space and inflammatory processes take place through relatively straight vessels with no configuration, and washout of contrast medium from the interstitial space is accelerated by active lymphatic flow. So it's quicker. Persistent enhancement is seen in some cases due to abundant degree of fibrosis as contrast remains in fibrotic portion for a long time. So again, it's not 100%. So you can see these lesions that the washout took longer because of the the malignancy. Next slide. There's also false negative, central necrosis, mucin-producing tumors. Next slide. And so this is the growth rate assessment. The volume doubling time is the time required for a lesion to double its volume. So they've got this mathematical equation, and so one volume doubling time is 26% increase in the diameter of the nodule. So this gives you a tip-off. Absence of growth over at least 2 years period, a reliable indicator of being benign, but honestly I've seen it where it did not grow till even after the 2 years. So none of these things is 100%. I just want you to remember that. Never hang your hat on a data. The data could be wrong or may not be accurate. Always have your clinical sense and your history and everything together, and that way you'll treat the patient better. The doubling time less than 1 month, infection, infarction, lymphoma. Doubling time 1 to 18 months, bronchial carcinoma. doubling time more than 18 months, granuloma, hematoma, bronchial carcinoids, doubling time for adeno undifferentiated squamous cell is 7.3, 4.1, 4.2 months respectively. Next slide. Slowest growing bronchoalveolar carcinomas have volume doubling time of more than 3 years. Yeah, that's what I'm saying. You can't go by that 2 year. Mets from testicular tumors and sarcomas have VDT of less than a month. So if it's growing fast or growing slowly, you still can't be sure. Next slide. You have the computer-aided diagnosis, integrated computer system that supports nodule identification, analysis of nodule size, morphology, textural analysis of internal structure of nodule by analysis of high-res CT data. So that's what we use for the robot, the high-res CT data, and we plug it into the computer, and that also helps us map as to where the nodule is exactly in a 3D position. The CAT system recognizes opacic lesions surrounded by lung parenchymal attenuation as nodules. Therefore, nodules in the subpleural, facial, and costophrenic angle areas might be missed. Next slide. Not helpful to pick up lesions less than 4 millimeter, really difficult. The smallest I've biopsied is actually 8 millimeter, which is with a robot. People have done even smaller and got diagnosis, so we're getting better as we do more cases. Don't replace the radiologist, I agree. Next. Role of dual energy CT and single pulmonary nodule. So you have this dual energy. You have one source of energy with the protons in the MRI, or you could have double dual energy, making it more accurate, but still not 100% more accurate. Okay, next. So role of contrast enhanced dynamic MRI. So that's another way they're trying to find it. Again, basically the story is the same. It's just benign, it's just malignant. So they're trying to get to the bottom of that. And this helps, but again, not 100%. Next. And they're showing whether the rim enhancement in benign lesions on the MRI. This is at 3 minutes. And then you have a more homogeneous uptake in malignant tumors. Okay, next slides. So just continuation of that they're trying to get the, find out if this is malignant or not. Next. Dynamic MRI has been used to assess tumor vascularity and interstitium. Next. So again, the signals help in differentiation. Next. Disadvantages of MRI, poor resolution. That's why we don't use it really for the rest of the lung, only for nodules. Cardiac and respiratory motion. Artifacts, difficulty in detecting lesion less than 1 centimeter. Not useful in peripheral single pulmonary nodules due to signal loss. That's why we don't use it as much. Role of PET scan. Malignant cells have upregulated metabolism and proliferate rapidly. This result is marked uptake of the FDG, false negatives due to carcinoids, bronchoalveolar carcinoma, adeno, and with BAC component. And for nodules less than 10 millimeter, remember, a PET scan is not the best. false positives, active TB, histo, coccidiomycosis, rheumatoid nodules, aspergillosis, Wagner's. So the possibility of malignancy with negative PET is less than 5%, but that's still 5%, so you're not 100%. Next. And you can see how the PET scan lights up. It also helps you with the metastasis. If you see lymph nodes, it helps you in staging. Okay, next. And this is the follow-up, Fleischner Society, and basically you have to keep an eye on these nodules and see if they're increasing, and you can do serial, like CAT scans and repeat CTs. I get nervous waiting for all this time to do another CT, so frankly, I just do some X-rays in the meantime, like in 3 months, just to, cheat and just to check on it, is it growing or not? And if there's a suggestion that it looks a little bigger, although it's not as accurate, I just go ahead and get a CT at that time and, break this protocol. Next. Management of solid tumor nodules, 8 to 30 millimeters in surgical candidates. So again, the sooner you're going to operate in these people, the better result. So what's the probability of cancer? Look at whether the patient's a smoker or other reasons, and then you can follow these the guidelines. If it's a very high probability, they just have it taken out. But I feel with the robot, everybody should get a biopsy rather than just taking it out, because it's so much easier and it's so accurate now that we shouldn't do major surgery without a diagnosis. Next. The diagnostic ability of thallium SPECT has been reported with sensitivity, specificity of and accuracy of 85 to 100%, 90 to 100, and 85 to 100 respectively. The diagnostic accuracy for the pulmonary nodules over 2 centimeters in size between SPECT and PET is almost the same. We usually use PET, and it's got an edge over the SPECT. Next. So you can see the basically the thallium SPECT for a single nodule. Next slide. Intermediate transvarsal needle aspiration biopsy for peripheral nodules, bronchoscopy, transbronchial biopsy, and video and VATS. Next. Next. So this is about granulomas. We see a lot here. Almost 90-something% are going to be granulomas in the nodules we see here, and their location close to pulmonary space. There's calcification, laminar, fleck-like, concentric, sometimes cavitation, satellite lesions, seen upper lobes. Next. So you can see these granulomas here. Next. Hamartomas, the less common, benign pulmonary mass. They have connective tissue, cartilage, fat, smooth muscle, marrow, and bone at times. Mostly peripherals, spherical, lobulated, popcorn-like calcification, and fat density with a mass. Next slide. Okay, so you can see that on the right costophrenic angle. Now on to our next, please. ABM. So well circumcised lesion with lobulated outline. Feeding vessels, that's the tip off. You see feeding vessels going into the nodule and draining vein. Confirmed on CT. So nowadays they have little stents they can put into coils and they can shut it off because it can cause shunting, makes the patient short of breath. Next slide. So you can see the lobulated, well-marginated nodule and the lower lobe. Feeding artery, arrow, you can see the arrow right there. An enlarged vein, so that's AV malformation. Next. So this again, you got an angiogram there, helps confirm the malformation. You can see the vein which is draining. The arrows signify that. Next. Rounded pneumonia, and you can see this. It looks like a tumor or something, but it's just an infection. It goes away. Common in children. So usually people have pneumonia, you've got a leftover pneumonia, because that pneumonia takes time to clear, especially in older people. You get up to 6 weeks, pneumonia start to clear. Okay, so inflammatory pseudotumor, sometimes pneumatic consolidation assumes the shape, sometimes there's scarring in it. Next slide. So the infarct is poorly marginated nodule peripherally to lower lobe. You see a lot of PE, and you see this peripheral sort of signs of infarction. Next. And vanishing tumor, sharply marginated with pleural fluid collection. And once the fluid goes away, they go away. Less than 4 centimeters usually. Next. Carcinoid, well-defined, rounded, lobulated lesion at the bifurcation, eccentric calcification. Next, please. Nodule eccentric calcification obstructing the posterior segmental bronchus of the right upper lobe. You can see that right there. And high-res CT show well-defined round, partially endobronchial nodule. That's the arrow. And the lateral subsegmental branch of the anterior segmental bronchus of the left upper lobe. You can see how it's blocking, and that's how you see it, endobronchial with the, very so profound. You see that it's blocked by the tumor. Next. And on the contrast enhanced CT, mediastinal have been doing the nodule, demonstrates marked contrast enhancement and mimics a vascular structure. So you see how it's like emphasis coming at you, and on the contrast enhanced CT, mediastinal, the nodule demonstrates marked contrast enhancement and mimics the vascular structure. So carcinoid are very, vascular, and they bleed a lot when you biopsy them. Next. Rounded atelectasis, folded lung, chronic atelectasis, X-ray peripheral. You can see the rapidly forming pleural effusion. Next, please. So, conventional tomographic scan, you can see the pleural mass. Next, please. Okay, we're done with these. Let's get the robot slides on. Hello? Hello? Okay. Hello? Yes, sir.
Sorry?
Yes.
Can we just take questions of these?
Yes, yes.
Running out.
Yeah, let's do the questions. Okay.
For the robot.
It's sort of short of time. So this is basically the robot, what it looks like. And I think it's time for questions. So any questions?
Good morning, Dr. Salim. My name is Dr. Suma. More than a question, first I want to compliment you for a wonderful talk. And I was especially intrigued in your image, which spoke about an air crescent sign. You showed us an image which was an air crescent sign. So can you please explain to me that when the cavity forms and then the nodule is growing in there, what is the clinical presentation?
Well, as you know, mostly there could be hemoptysis because it is causing disruption of the blood vessels. So usually we see hemoptysis. And of course, we see the symptoms related to the original, problem, the disease. Over here, we see a lot of aspergillomas. Whenever you have this cavity, you have the aspergillus, growing in it, and it does cause, hemoptysis. And basically, we have to treat it with the antifungal, which can cover aspergillus. That's really common, if it's not malignancy. Okay. Any other questions? So, in interest of time, we're not going to see all the robot slides, but I think I showed you the robot. So basically, we use that. It's thinner. It can get to the periphery. We can get right next to the nodule because we fed the high-res CT into the computer. We are controlling. It's like a PS4. We're controlling the robot with a PS4 type controller. So it's very accurate, and we're getting great results with it, with smaller nodules, and therefore going on to surgical or whatever other treatment is needed with great results. Thank you. If there's no other questions, thank you for listening.
All right, thank you very much, Dr. Mohammed, for that enlightening keynote address. Your insights have set the stage for an extraordinary day ahead.
Now, let's take a glimpse of what lies ahead in our agenda today. We have thought-provoking research presentations lined up so that you can have the opportunity to delve into a wide range of topics and explore the latest advancements in medicine.
Our final keynote speaker for today is Dr. Bolu Adeyemi, presenting his work in computer simulations as an essential tool for drug discovery.
Dr. Adeyemi grew up in Nigeria and graduated from the American University of Barbados School of Medicine. He's an internal medicine resident at Chicago Medical School at Rosalind Franklin University.
His research experience is in computational biochemistry and has had multiple studies presented at bioinformatics conferences and experimental biology conferences within the U.S. Today, he joins us as a representative of the American Medical Student Association, also known as AMSA. Please give him a warm welcome.
Hi, everyone. I'm hoping you can hear me. Can someone confirm if you can hear me? Hello?
Yes, Dr. Adeyemi, we can hear you.
Okay, perfect. Yeah, so hi. I've been introduced already, so I'll just, as they said, I'm at CMS. I'm currently in internal medicine. And so I think let's just jump right into it. So how do I get my slides up here?
Yeah, we are shortly presenting your slide. We'll be there in a couple of seconds.
Sure. I can't share my screen now. It would be you controlling the slides, yeah? Okay. All right, yeah, so as soon as the slides are up, we can start.
Okay, Dr. Adeyemi, can you see the slide?
Thank you. So my topic is, you see it, it's computer simulations as a tool for drug discovery. So that's the area where I've done some research work. So yeah, that's what we'll be talking about. So let's go to the next slide, and I'll give you a brief overview of what we're going over. So there's the introduction, which we kind of already completed. And then you can see it's just like 5 main points, or 4 main points actually, that we're going to talk about. We'll talk about the drug discovery pipeline, so that I can orient you to where I am or where I've been in that pipeline. Then we'll talk about like how it's been done, how it's currently being done, and future directions in this area. So let's go to the next slide. Yeah, that's me. My research so far has been on these 4 proteins. So I worked on SOD, that's actually my first study, is a protein, an enzyme that's implicated in familial ALS. So there were a couple of interesting findings, which actually I'll go over later in my presentation. And then the other studies have been on COX, on IPP protein from diabetes, and the most recent one I've done, obviously, is some work on the COVID spike protein. I'll actually show you an interesting thing from that study later on in the presentation. So let's go to the next slide. Okay, I don't know how clear this is because it's not particularly clear for me, but I'm hoping all of you can see it well. So there's a drug discovery pipeline which has these different phases that you're seeing, and there's target. I'll go through them and then I'll explain just briefly what each of them are. The one most people will be familiar with are the last 4 at the end: phase 1, phase 2, phase 3 clinical trials, and then approval to launch. Phase 3 those are usually like the big ones that you hear about. So it's like, okay, this drug is in phase 3 trials and all. But the part where I've been is the one before that, the first 3, where you see target validation, which just says, okay, this is the thing we're targeting in the body, right? Like for me, it was SOD protein or COX protein or the COVID spike protein. So you decide what you're targeting and how you want to target it. The second thing you'll see there is compound screening, which is actually where my research has been. So if you just click, not to the next slide, but it's supposed to highlight compound screening. And so that's just to show that, okay, that's the area where I've been. That's kind of what we're going to talk about today. And there's lead optimization, there's preclinical tests, and you guys will all have this when you go through your pharm course. Actually, you're going to get tested on knowing this drug discovery pipeline. So maybe you're going to score 1 or 2 points just having seen this presentation. But let's click to the next slide. Yeah, and that's just highlighting that compound screening is where I have experience. And so how that works is that you you take the targets. Let's say I was looking at the spike protein, for instance, and you know that there's this library of molecules that for whatever reason you've come to believe that they may have activity against that protein. Then you run some computer simulations to help you figure out, okay, is that true? Is there any of these molecules that does bind? If it binds, what does it do? And you can actually model a lot of that stuff in silico, which is to say, your computer, before you end up getting to, further stages. So how it works is, if the molecule looks like it's behaving well, in silico, then the next step is in vitro. So you take some actual protein, you put it in a test tube, you take the molecule you're studying. If it still looks like it does what you've predicted, the next step is what you see there as preclinical. Well, actually, there's lead optimization in between. You just tweak the molecule a little bit, but then you go to preclinical, which is, you may have heard of studies with guinea pigs and monkeys and so on and so forth. If the molecule still looks like it's doing what you're expecting and it's safe and everything, then the drug goes on to human trials, phase 1, phase 2, phase 3. So that's kind of the pipeline. Now you know kind of where I'm at in there, or where I've been. So let's go to the next slide. And so actually just click through until you hit all the bullet points on this page. When I made the PowerPoint, I forgot to account for the fact that I wouldn't have control. So just click until you see all the bullet points to the bottom of the slide. So the first thing is just to talk about some historical context, is that early drugs were made kind of based on herbal remedies. Can we click through on the side? Yeah, just keep clicking through until you see acetylation and purification. Then you know that, okay, we're at the bottom of the slide. Just keep clicking through. Click, click, click. Continue clicking. Thank you. So yeah, early drugs are based on herbal remedies, and not even just early drugs. In many of our home countries, or I don't know where you guys are from. I'm from Nigeria, and there, and in kind of Africa as a whole, and in all of Asia, and actually everywhere, there are native remedies that people have passed down from generation to generation. That's what you call ethnobotanical knowledge. And in the past, people used to actually explore, find drugs find like plants that have activities. If anybody has seen and remember that movie Anaconda, they were looking for some orchid with special pharmaceutical properties. That's how drug discovery used to be. And then you had discoveries that were just lucky, right? Like penicillin. So that was kind of in the past. Then they would isolate, purify those compounds, and test them in labs and see if they did what people were hoping that they did. That was kind of in the past. Now we have more advanced technology. So go to the next slide. And here we start seeing, yeah, just like before, click through all the way to the end. You can stop after the red box pops up. There we go. So these are the current technologies, and I've highlighted the ones in the red box just because that's, like I said, where I've been. But just to give you an overview, you have high throughput screening, which is, you can see in the top right, there's a picture with like a microarray, and that's just robots actually testing a bunch of samples to see if the molecules that you're thinking might have an activity do have the activity that you're predicting. If they do, you have a hit, and that molecule goes on for further studies, right? But then the ones in red, that's where it's like, okay, this is the gist of what I'm saying. You have molecular docking and molecular dynamic simulations, which is the first one, really. Molecular docking is where I've had the most experience, and so I'll talk most about that. But then you also have ligand-based drug design, computer-aided drug design, which is, I have a picture of that at the bottom right of the screen. You can see that they've overlapped a bunch of molecules. And what that is it's called pharmacophore modeling. And so they take the molecules, they overlay them and say, okay, this has dysfunctional groups here, it has this kind of structure there. And based off of like a bunch of molecules that they know that work, you kind of build a model for a molecule with these properties, this structure, these functional groups in these kinds of places should have this biological effect, right? So I haven't done any work in that, but it's a really fascinating field of drug discovery. And then, of course, like I said, you can move on to in vitro experiments, actually in test tubes, and then you can do ADMET predictions, which is absorption, distribution, metabolism, excretion, toxicity. You can predict a lot of those things with software now. So let's talk some more about molecular docking, which is actually before molecular docking, I think I have one more. So click through to the next slide, please. So this is just an example of the kind of hardware that's deployed in these computer simulations. And so the left, I have just a small list of computers that are used in this kind of research. On the right, you have a picture of the Summit supercomputer, which is located at Oak Ridge National Lab in the US. So that is actually the world's 5th most powerful supercomputer. And one of the things it's used for is running these calculations for drug discovery. And then I don't have pictures of the rest, but Stampede 2 is another supercomputer at the University of Texas in Austin. It's the world's 56th fastest, most powerful supercomputer. It's also used partly for drug discovery research. And then you have computing clusters, which they operate a little differently than supercomputers, but it's still a massive amount of computing power that universities often deploy to help study these things. So I haven't had access to anything like that. Honestly, all the research I've done has been with my PC, which is unfortunate. There's a lot of stuff you want to do. You want more computing power, but you work with what you have, right? So these are out there. People are working with them, not me. So let's go to the next slide. So here is these two pictures are actually real images of like what the workflow looks like in my research that I did. So the one on the left is just an example of actually running calculation. So I'll explain what's happening here. On the right, that is an actual protein structure that I have worked on. That's the structure of the superoxide dismutase enzyme, which I said is implicated in ALS. And then you can see those balls, blue or cyan or whatever, and bronze. This is just ions in the protein structure. And you can see molecules kind of on the left and right, green and orange. Those are overlapped ligands that I was working on with this protein. So essentially what happens is that you take a structure of the protein that the computer can understand, which is the protein structure you see there. And then you take a structure of the ligand, again, that the protein can understand. And there are databases where you can download and generate and validate these things and all. But digital forms, essentially snapshots in time of these structures. And you can actually put them together in a computer simulation and calculate, based on some scoring algorithms, how they will interact with each other. So this was like the backbone of my research, was doing these calculations to see how certain ligands interact with certain proteins. And like I said, based off of this, when you do a bunch of virtual screening like this, you might generate leads that you can then optimize and take into in vitro experiments, which again, I never did. Those require a lot of funding. But yeah, theoretically, let's say you've predicted something and you'd like to test it further, then you go ahead and design an in vitro study. But I never had the resources for that when I was in med school. So this is the extent to which I reached. So I'll just explain what you're looking at here. This mode of binding where you can see that the ligands were between the two halves of the protein, the prediction we made from those calculations was that these ligands would probably stabilize that protein structure and make them less likely to unfold, which would go on to prevent them from aggregating. And we know that aggregation is a big part. The process to aggregation is a big part of the disease process. So that was the conclusion that we made from that study. So we can actually go to the next slide, and I'll show you what results look like from these simulations. So on the left, you have a table that just reported some amino acid interactions that we derived for how these ligands are interacting with the protein. And on the right, you have a picture that I generated during that study that's just showing a molecule called chlorogenic acid and its interaction with the protein as we had calculated it. So this is a more detailed view of the picture that was there in the previous one. That's just highlighting the interactions we found in much more detail. So that's molecular docking, and essentially it's a very good starting point for this kind of research, but it's limited in terms of these structures, as the computer understands them, are frozen in time. So you can think of it like, if I take a picture of you, wherever you are, and I look at that picture, I can derive a lot of information about you just by looking at that. But if I want more, it would necessitate actually observing you across a period of time. And that is the limitation of this study, is that we all know, as you're in med school, so you've taken biochemistry probably, or will soon take biochemistry. And so that protein structures are dynamic and their secondary structures change sometimes depending on what's happening. So if you can only simulate one point in time, while valuable, that's of limited utility. So that's where the next step comes in. So we can go to the next slide. And what you have now, you move on from molecular docking to molecular dynamic simulations. These are actually much more interesting to me, and unfortunately, they require much more computing resources that I didn't have access to. But what's happening here is that this protein ligand interaction that you've simulated in molecular docking, you take it and you allow yourself to simulate it over a period of time, which allows you to make much more accurate predictions about its behavior. So on the left, you see a protein structure surrounded by some molecules and some other stuff encased in a box. And so what that is that you take the protein and you tell the computer that this is this protein and this ligand. They are dissolved in this solution that contains, it can just be water, or it can be water plus ions like sodium, chloride, potassium. You can simulate the intracellular environment if you want. You define the pressure of the system, the temperature of the system, and then you confine it to a certain volume, right? So you've added a whole lot more parameters that allow you to much more realistically simulate the behavior of the protein, and then you let the simulation run for a period of time. So on the right, you're seeing some outputs, some results of this kind of simulations, where they usually run across 10 nanoseconds. So the top graph on the right is labeled in picoseconds, but 5,000 picoseconds ends up being 5 nanoseconds. And actually, they often run for much longer than 5 nanoseconds. These kind of simulations run for 10 nanoseconds, even 50, depending on the kind of computing power that you have access to. But what the results shows is between the RMSD and the RMSF you see there. RMSD just means root mean square deviation. It tells you how the structure of what you're looking at is changing over time. And then the RMSF is the root mean square fluctuation, is telling you about specific regions, how they're moving across time during your simulation. And so Essentially, just to simplify, you want to see your RMSD like become very stable and remain stable. And what that will mean is that whatever you've simulated actually like remain stable. So let's say you take ibuprofen, for example, and simulate it with cyclooxygenase. We already know that ibuprofen is an excellent inhibitor of cyclooxygenase. You should see that combination remain stable over time, which tells you that it's very good, very strong, very significant binding that you're looking at there. The results in this study showing the RMSD kind of like slowly trending up. I didn't read the paper I took these results from, but most likely that means that the simulation showed that the predicted binding wasn't stable. That's most likely will be the conclusion from this study. But it's a very interesting kind of experiment to do. It's all done in silico, you know, as in with your computers. But like I said, it's where you can do molecular docking with a PC, not even a very powerful PC. Most PCs can run molecular docking calculations. Molecular dynamics requires a lot more hardware. So I haven't done a lot of that. I didn't when I was in med school. Which is when I did all these kinds of research. So the like computing clusters you saw in previous slides, they're often like, those are the kinds of systems used to run these calculations. So yeah, then after that we have future directions, which is, yeah, kind of nearing the end already, which is just saying, okay, this is where the tech is headed next. You can click through to the end. And so the two, I think, biggest technologies in this space are machine learning and quantum computing. Machine learning is essentially the process that drives artificial intelligence. You train your neural network and it becomes capable of very, very powerful things, which I'm sure you've all experienced in one way or the other. ChatGPT, Google Photos, recognition, or whatever you're using. And you can use it to predict protein structures. You can actually theoretically use it to do all the things I just explained. But instead of using just pure logic or Newtonian physics or scoring functions to run calculations, you can actually just have a neural network do it, which is a very different process, but it's very highly accurate. So those are some future directions. And then quantum computing is also an interesting technology that allows much more powerful computing than we currently have access to. So just to give you some sense of the impact that quantum computers can have. Currently, the best encryption, which most of us are using without even thinking about it, but the best encryption algorithms on the market, it would take the fastest supercomputers maybe 16 million years to crack an encrypted message. A supercomputer could do it in, a quantum computer, could do it in maybe minutes, maybe hours, so that's the kind of difference in computing power that we're talking about. And when you apply that to calculations like this, it suddenly unlocks a world of possibility, right? So let me show you, let's go to the next slide. I'll just show you a small way where I've applied AI in my own research. So the second point is just a little joke because I used ChatGPT a lot when I was making this presentation. That's already one application. But the interesting one is the picture that you see, which is it has been an age-old problem in biochemistry that you take the two-dimensional, the DNA, it's just a one-dimensional instruction for protein structure, but anywhere where you express that protein, if it's that same nucleic acid arrangement in humans, in yeast, in bacteria, it will always take exactly the same shape, which tells you that that conformation detail is stored in the DNA. And how exactly that happens, we've never fully understood. Until this day, algorithms still aren't able to do it. But artificial intelligence can. And that's one scary thing with AI is that we train it, we know it works, we don't know how. And so what you see on the left is is a monomer of the COVID spike protein. When I was studying it, I needed to get a specific configuration of a part of that protein, which didn't exist in the online databases. So I thought, okay, maybe I could generate that with artificial intelligence. And I did, which is the little structure you see on the right. There's a reason I put them in the same window. So that blue protein was generated by a revolutionary new piece of AI that is able to predict protein structures with similar accuracy to actually resolving them experimentally, which is huge for biochemistry. So let's go to the next slide. And this is my second to last slide. So what you're looking at on this slide is that after I generated the protein structure from the DNA, the nucleic acid sequence of the protein, I wanted a way to validate it to see that, the structure I've generated is it's accurate. It's like the one I'm actually trying to study. So I took the structure that was experimentally resolved, either with X-ray crystallography or NMR, it doesn't matter. It's like they put the protein there, they take an actual picture of it using very high-tech scanners and upload that. I'm simplifying a lot, but then they upload that into the computer, and that's what the computer understands. So the big structure is actually experimentally resolved, whereas the blue one I generated using artificial intelligence. And to validate them, I did structural alignment, which you see here, and you can see how closely that the AI generated structure aligns with the other one. So then I ran my simulations on the AI generated structure, and I found some interesting results. But yeah, that was one of the more interesting parts of my COVID research. And let's go to the next slide. That's my last slide. It's just a summary of everything. And yeah, not just simulations, but all the tools that I've just gone over. It's opening a lot of doors for pharmaceutical and medical research, which is very exciting. But yeah, you can see I put there that 17% resolved experimentally. What that means is that of all the proteins in the human body, only 17 have been experimentally resolved. Like I said, they put the protein there, they make a crystal structure, and they take a scan of it that can be manipulated in computers, which means there's 83% that's not resolved. That 83% is the potential for AI to help out with, just like I've already started applying in my research. So that's very exciting. More can be studied, and you can do the same thing with ligands. You can do the same thing theoretically with the simulations themselves to see how they predict. You can use the same machine learning models to predict the kinetics or dynamics, the absorption, distribution, metabolism, excretion, toxicity, all that stuff you can predict. And so that's kind of where it's headed. I'm not doing much of this anymore. I'm doing some because I still work with my mentor from med school, but yeah, most of this I did in med school. So that is kind of the end of my presentation. If you go to the next slide, I think it allows for some questions. And if anyone has questions at this time, I would be happy to take them.
Thank you very much, Dr. Adeyemi. Your presentation was fascinating. We understand that engaging in such intellectually stimulating discussions can be draining. Hence, we have scheduled a few breaks throughout the day during which you can enjoy some refreshments and take time to network with your peers.
We will now be going for a coffee break, and we ask that everyone return to this hall by 10:45 sharp. Make sure you check in at the front desk for attendance. Thank you.
Sharon, come to the stage.
Okay, they're going to introduce you. No worries.
Hi, Cristo. This is Dr. Amin. Yeah, we are projecting his slides and his video feed also. Give us a couple of minutes, okay?
All right, everyone. So we're just going to ask everyone to return to their seats so we can commence the next presentation.
Welcome back from your break, everyone. As the day unfolds, we encourage you to actively participate in the discussions during the Q&A sessions and network with your fellow researchers during the breaks. Remember, this conference is not only about learning from the experts, but also about exchanging ideas and forging new collaborations.
Our next presentation will come from Dr. Herbert Emmanuel Oye. Dr. Oye is a vascular surgeon who has an active practice in Beckley, West Virginia. He completed his fellowship at the Arizona Heart Institute under the tutelage of the late Dr. Edward B. Dietrich. His areas of clinical interest are carotid endarterectomy with minimal incision, endovascular and open abdominal aortic aneurysm repairs, limb salvage revascularization, and innovative endovascular interventions.
Apart from his distinguished medical accomplishments, he has spent a great deal of time in his home country, Nigeria, in the pursuit of improving medical education and access to medical care. He has founded and sponsored various healthcare organizations, and lastly, he is an amazing mentor to the future generation of students. It is for this reason he felt that medical students should be aware of what lies up there in their future lives as physicians. For our presentation today, he wishes to pass on his wisdom to us junior doctors.
Today, Dr. Oye will be discussing his take on life beyond medical school. Please give him a warm welcome.
Hi, Dr. Oye. This is Dr. Amin. You can unmute yourself, sir.
Yeah, perfect. Thank you very much for the kind introduction, Mr. Chairman, ladies and gentlemen, doctors to be. And that's my kind pleasure to be here today. And I'd like to take this opportunity to thank you all for the invitation. Life after medical school, a blueprint for success, as the title of my book in making, and I felt it would be right at this time to share some of the core principles I believe will be helpful to young physicians who are about to partake on this journey. What is life after medical school? What does it look like? Before you get into life after medical school, you have to have life before. Life before medical school starts with high school experience. And the high school experience will tell you whether or not you're well prepared to take on the challenges of college. And after college and the excitement of college, you'd go on to medical school. Our avenue at arriving into medical school usually is varied. Some people know that they'll be doctors way before medical school time. Others don't know until the very last minute. No matter what avenue we take to reach that goal, at some point we'll get to medical school if we so desire. When we get there, the demands and rigors of medical school, toiling day and night, endless examination, board exams, which will even go beyond medical school, will continue to linger in our lives. So it's important that as you go through medical school, you enjoy the challenges of medical school, because life is going to be totally different for you once you finish medical school upon graduation. So you graduate from medical school. What does that mean? Do you know what it takes to survive in the brutal world of clinical practice? Have you thought about it? In medical school, pretty much, you really have some responsibilities, but the responsibilities are usually not as great because you're not practicing on the license, you're practicing on the license of your terms. So once you graduate, you become board certified or in clinical practice. It's all about you and what you do. So it's important that to understand that for you to survive the brutal challenges of clinical practice, if you're not prepared of answers to no to that, then you have to listen very closely, attentively, for you might gain a few insights or words of wisdom that may protect you and your clinical practice in the future. Then you will cruise on to residency and fellowship. And again, that comes, there will be small challenges. You have to apply to multiple institutions, do the match, get matched or matched, just scramble. You go through the process and you're lucky to get into a program. And once you get in a program, you hopefully perform well. If you're being trained well in your extension program, you might be able to now perform well on your residency program or even your fellowship program, then ultimately gain good ability to get a job someplace after your training. What does that look like? How does your clinical practice start? Your job search. Watch out for, very important job search. You have to watch out for this non-compete clause that you might see in many contracts. Because if you sign a contract and it says non-compete, that simply means that if they like you like them, you start the contract, you start working, and for some reason something happens and you all have to divorce the arrangement, the institution will expect you to leave that community pretty much in most instances for a distance of 25 miles or higher. So you want to be sure that if you can avoid a non-compete clause in your contract, you want to do that up front. If they like you so much, if they're so inclined to give you the opportunity to work for them, then they should leave that non-compete clause out completely. But if you cannot get rid of it, then the other thing you ought to do is to make sure the non-compete becomes so limited that it doesn't affect your lifestyle should you leave or decide to leave for one reason or another. And there are many reasons why persons may want to leave. Again, it's always good when you sign contracts to not to breach the contract, because again, if you breach the contract, they can sue you for breach of contract, and that may sometimes involve legal matters that would drag you into some expense. So it's important as you read any contract that you watch for that clause non-compete. It's very important. Sometimes you come to community, you're settled in, you like the community, you're doing well, and something happens and you have to leave. Non-compete means that you have to really uproot everything you have in that community to start someplace else. So it's important to look into that. Now, once you start your job search, you have to decide if you want to go into urban practice or rural practice, private practice or public practice, clinic plus or minus hospital responsibilities versus hospital responsibilities 100% versus academic or missionary work. So those are things that you have to think about. Either if you want to be in the big, some person many years told me you want to be a big fish in a small pond or a small fish in a big pond. So you kind of see the analogy. You want to be big in an urban center, then you have to compete a whole lot more people in the urban center. If you're in a small community, you compete less. So it depends on your preference and your overall take on it. It's important that when you negotiate for a job, that you negotiate upfront what you want. Remember, the person on the other side, the administrator for the hospital or the entity that you want to work for, they're always going to do what's in their best interest. They're not going to do what's in your best interest. So you have to speak up, negotiate, read whatever contract they're giving to you, get the services of a trusted attorney. Because once you sign that contract, it becomes very difficult for you to now ask for things that you should have asked for in the first place. They expect you to ask for it upfront. They're not going to tell you to ask for it. So you must get the services of your trusted legal expert to help you navigate that problem. You must believe in what you're worth. And if you know your worth, you must therefore negotiate upfront for everything you want. Don't wait until the last minute. Again, remember, you have to do what's best for you and what's best for your family. One of the challenges we get over the years in clinical practice, and why I said life after medical school, even medical school, you see some of the challenges. You have to balance your academic work with extracurricular activities. And if you're married, it's even worse. You have to balance that and that of your family needs. So it's important that as you work hard, you have to work smart. You have to allow time for you to unwind, time to refresh or reboot. You have to develop good work relationships with your peers and other staff members. Do not allow your family to suffer from your continued absence. Make time for your family events, trips, children games, activities, sporting events, and all that. Those are things that would make you better at the end of the day, that will keep that life balance going for you. It's important that you understand that if you're young and you get married after you finish your training and your partner or spouse is also in the same boat, married with to you, and you may have one or two or whatever number of children you may have. In the meantime, you maybe just got married, you have to have a wedding to plan it, or have planned a wedding, you've spent lots of money, you get a job, now you want to buy a big house, you want to get some other things, luxuries, things in life. All this is expensive. Now, what happens if you don't plan well and you run into financial difficulty because you've chosen the wrong field or you've chosen the wrong contract? This can lead to financial discourse, and if your spouse is not understanding enough, it can lead to divorce. That's one of the bigger issues that's led to divorces in marriages, where the husband and the wife who cannot see eye to eye on account of the difficulties that the practice, your clinical practice, challenges it creates for your family. So it's important to maintain that family balance, understanding that you must work hard, but at the same time, you must make time for your family. Financial discipline, therefore, is important. If you're married or unmarried, as you work hard, you must work out a double plan for payment of your student loans. My suggestion, advice is if you can work hard and pay your loans out within 3 to 5 years, you're better off for it. Do not stay before buy major real estate until you have job security. That really should put you around the 3rd to 5th year from when you graduate. Pay for your home totally if you can within 5 years, and keep at least 30% of every dollar that you earn in savings. Take only 10% of your savings for risky investments. Don't go into big gambling situations, excessive drinking, and unprofessional acts, because those actions can come back to haunt you in the future. Increase your disability. It's important as a medical student, from this point that you're a medical student and beyond, you really should look at getting a disability insurance. If you've not had one, you must have one, because you never know what may happen in the future. So it's important that you get disability insurance and build on that insurance profile as the years go by. As your income increases, you're able to buy more into that. Because I've had situations where a physician, healthy, double-boarded surgeon gets, fired from a job, and all of a sudden, at the same time, gets a stroke and renal failure, and all of a sudden, the person's life is completely gone because there's no disability insurance that was there. If you had disability insurance ahead of time, even though you're faced with medical challenges, at least you're going to be paid a fair amount of what you're worth. So it's important that you do not take this lightly. If you leave this talk, you must start, if you don't have one, disability insurance, shop for one, and just slowly build into it as you go on, because it will be helpful during the rainy days when things get tough. You never know what can happen in the future. So do not plan to fail or plan, do not fail to plan or plan to fail. So it's important that you do that. It's been said in the African adage, only a fool will test the depths of the rivers with both feet. So I take it as, if you've gone through medical school, you're definitely not a fool. So you're not going to put both feet in and test the depths of the river. You probably will take one foot at a time. So what is good enough for the wise. For your children, set funds aside for college, and when they are in elementary school. Don't wait until the high school students for you to start worrying about getting the tuition for college. That takes too much time. So planning is very important. Allow them to see the world so they can concentrate during college days. If they've seen the world, then college becomes a lot easier for them, because the distraction of college becomes less of a problem. So save some money now once you start your job, and so that by the time your children become teenagers, they can at least see the world. Work hard, and during work duties, it's important to have good documentation. That will save you from legal anguish and nightmares. Date and time your entries of patient care on the patient's chart. Treat all patients the same with respect and dignity. Rich or poor, old or young, black, white, or brown. It's important that you have the same standard for treatment of your patients. If you don't have the same standard, or if you treat somebody because they're wealthy or they're VIP, you run the risk of making mistakes. So do not have varied standards for VIPs versus non-VIPs. It doesn't matter if your patient's homeless. It doesn't matter if the patient's present in the United States. If they're your patient, you treat them the same way. Treat every employee at your hospital and clinic office with respect and dignity. Be humble at all times. I will tell you, give you a case review that you might find exciting. Several years ago, I was on call, vascular surgery, and I got a call from the hospital that the patient had abdominal aortic aneurysm that was ruptured. So I came in, took a look at the patient's CAT scan, didn't see any evidence of rupture, saw the patient in the ER, and I can remember vividly the patient was in ER room 17 and to the hospital. I talked to the patient. He was laying in the bed. The daughter was sitting in the chair. The son was standing next to the daughter and right inside the daughter. And introduced myself and examined the patient and found out from my examination that he had abdominal pain for about 2 weeks. Then examined him. He had an obvious abdominal aortic aneurysm. Obvious. I mean, anybody who touches the abdomen would know this person has abdominal aortic aneurysm. Now, what happened was the patient was in the ER at a different hospital and was annoyed because he was not being attended to, so left that hospital, came to the second hospital, was in the second hospital at 11 a.m. in the morning. At 1 o'clock, the ER physician sees the patient. And at this point, the ER physician declares that the patient may have appendicitis versus cholecystitis versus diverticulitis, and proceeds to order an abdominal aortic aneurysm, not repeat, but order a CT of the abdomen with IV and oral contrast. And following that, this was about maybe 2 o'clock. At about 6 o'clock, I get a call about the patient with potential aneurysm rupture. What do you think may have happened in the time space? What did the doctor do that you shouldn't have done? Those are the things that you must know. Again, when a person comes in to your clinic, ER, anywhere you examine the patient, always your encounter with the patient begins with the history and physical. That has not changed and should not change. Your encounter with the patient before you order esoteric testing should start with examination of the patient. If the ER doctor had truly examined the patient, he would not make a diagnosis of appendicitis versus cholecystitis versus diverticulitis when the patient had an obvious bounding abdominal aortic aneurysm. So it's important that you touch your patient's belly every time you see them. Now, this patient, as luck would have it, I was on call. The aneurysm was 6.7 in diameter, so it was obvious. Then, because the doctor ordered CT of the abdomen with oral IV contrast, that means that the patient was given oral contrast. He has to wait several hours before the test was done. Wasted time, because all this patient needed either way was either a CT without contrast or a CT with contrast. And the patient's diagnosis of abdominal aneurysm would be confirmed easily. So this patient, other problems the patient had included bad heart, bad lungs, INR greater than 3, and with this diagnosis of abdominal aneurysm that was leaking supposedly. I saw the patient, there was no leak on the CT, and we proceeded to work in the patient up because of his comorbid medical conditions to see if we could do endovascular intervention the next day. This is around 7 p.m. already. Called, made all arrangements. Blood pressure was 200 systolic. Sent him to the ICU, put him on nitro and drip, and also proceeded to give him some medication to reverse his elevated INR, vitamin K. And what happened several hours later was an overt rupture. The patient actually did rupture 3 hours later, and had to open his belly in the ICU because the code blue was gone and clamped his aorta, got his pressure back, took him to surgery. Unfortunately, he died. And you must remember, what's going to happen once something like that happens? Who gets sued? The surgeon. This patient's been more ER for several hours, been in the ER in second hospital from 11 o'clock to 6 p.m. But the surgeon who did everything to kind of rescue situations one that was sued. So that those are the things that can happen. It's important that you document. Again, I was a surgeon question. I'm like, I didn't do anything wrong, so I therefore would have to not settle in this case. Took the patient to went through a legal process and won. Again, the reason why I won was simple. I recorded what my consultation interaction with the patient was at the moment it happened, in real time. But date, time, and it's indicated patient was seen in the presence of of his daughter and son. Those were the words that made me win that case. Again, it's important that you understand that you have to be careful in your entry. You have to be very careful when you examine patients and also record your findings. So don't make mistakes that could hurt you. In conclusion, I'd like to say, as you pursue life after medicine, a few things that you may want to know, keep in mind to make you better are full. I call them the ABCs. A, you have to aim to achieve. You already have that. You've made it already. You're achieving. You're here already. B, you have to believe in yourself. C, you have to be confident, not cocky. No one was born a doctor. It's an acquired skill. D, you must have discipline, which I believe most of you have, and determination to succeed. E, you have to show effort and efficiency at all times. F, you must have focus, and family and friends, keep the good ones, keep the bad ones away from you. You have a gift from your creator, so use it wisely. H, hard work, honesty, and humility are very important. And above all, you must have P, passion for what you do. If you have passion for what you do, you will be successful. Thank you.
Does anyone have any questions?
Any questions?
Thank you so much, Dr. Oye. I really appreciate you taking the time to share your stories and thoughts. I just had a question about your background, actually. They mentioned that you are performing or researching the surgery of endovascular without incision. Can you please elaborate on that?
Dr. Oye was called away to surgery. So any questions that are asked, I will get them answered and we can email them individually. Thank you.
We truly appreciate your time and expertise in delivering such an engaging presentation, Dr. Oye.
Our next presenter is Dr. David L. Stewart. Dr. Stewart has been an attending physician in general surgery for the past 15 years at Beckley Appalachian Regional Healthcare Facility in West Virginia. He began his career in Beckley shortly after completing his general surgery residency at Marshall University School of Medicine in Huntington, West Virginia. Dr. Stewart has been the chair and Department of Surgery for the past 5 years, and since 2021, he has also served on the Council of the West Virginia College of Surgeons.
In the field of medicine, Dr. Stewart has won many research and scholarly awards. In addition, he has posted numerous publications and presentations. Prior to entering medical school at Howard University College of Medicine, he won an All-American Scholar Award and several championships for his athleticism. Please join me in giving Dr. Stewart a warm welcome. Dr. Stewart, if you could just turn your camera on, please.
Good morning. I will be presenting. My name is Itunu. Well, there's Dr. Stewart here.
Hello, I'm actually on vacation, so I'm doing this from a hotel room. So I wanted to. Itunu is going to be presenting, but I will be adding my comments, and at the end of the discussion, any questions I can answer those. Itunu, you can continue.
All right. Good morning. My name is Itunu.
Hi, Dr. Stewart. This is Dr. Amin. We are pulling your presentation also, so just give us a couple of seconds.
That's fine, thank you.
Hello, Dr. Stewart. Can you see the presentation's first slide?
Yes, I can see those.
You can go ahead, sir.
Go ahead. Okay. Good morning. My name is Itunu. I will be presenting this case report that I had the pleasure of working with Dr. Stewart on. And thank you for this opportunity. We'll be sharing a case report about the foreign body in gestation, which caused a prolonged illness course with significant GI complications in one of our patients. Next slide, please. Sorry, we have a trauma, so there's a helicopter in the background. That's why it's really loud.
That's for Dr. Baker's. There's a trauma that just came in.
Yes. Okay. Next slide, please. Okay. So foreign bodies are ingested and usually expelled from the GI tract without any issue. About 80 to 90% of ingested foreign bodies will be excreted from the digestive tract without any complications or morbidities. However, about 1% of these foreign bodies, especially if they're large, sharp, or pointed objects, will cause or could cause bowel perforation. Next slide, please. Next. Okay. So this is an interesting case with a complicated hospital course due to a small bowel obstruction, perforation with ischemia, which retrospect was caused by foreign body that may have been missed during workup. Next slide. Okay, so our patient is a 53-year-old female with a history of type 2 diabetes, hypertension, chronic kidney disease, and obesity. The patient initially underwent orthopedic surgery on November 30th for a right hip arthroplasty. Next slide. All right. So post-operative day 8, the patient presented with severe abdominal pain and abdominal distension. The abdominal exam showed a tympanitic and distended abdomen. Leukocytosis, we saw a white blood count of 51. And the treatment was an exploratory laparotomy at the time to rule out bowel ischemia. Next slide. So actually the images that prompted the surgery, the patient had pneumatosis intestinalis, which is air in the bowel. And you can actually see there shouldn't be air in the bowel, and you can see the distended loops of bowel as well. Next slide. So in surgery, upon opening the patient, we saw a copious amount of purulent drainage in the pelvic cavity. There was infarction of the anterior portion of the cecum and a portion of the ascending colon. The appendix was swollen, but it was not perforated. And so we resected the terminal ileum and the lower ascending colon. So right here, you see an image of the, actually, you can go back to the last slide, please. You can see the image, thank you, the image of the necrotic cecum that was resected. You can see the purulent exited on that necrotic cecum. Next slide, please. So 2 days later, after that first surgery, the patient was returned to the operating room for exploratory laparotomy as a planned procedure. We found leakage in the ascending colon, and the ileum and the ascending colon were anastomosed via end-to-end technique using silk sutures. The lumen appeared intact and patent, and there was no evidence of leak using the leak test towards the end of the surgery. Next slide, please. Okay, so now 5 months post those 2 surgeries, the patient returns to the hospital with abdominal pain, vomiting, nausea, a tympanic and distended abdomen, also just kind of pointing towards a small bowel obstruction. The CT confirmed that, and there was a transition point at the anastomosis in the right lower quadrant. Treatment at the time was gastric decompression with the NG tube and IV fluids. The patient improved and was discharged on May 19th. Next slide, please. However, 5 days later, on the 23rd of May, she returned with severe abdominal pain in all 4 quadrants, nausea, vomiting, and a distended abdomen. White blood count showed 16.13, and emergent laparotomy was done to resolve the obstruction, identify and resect the suspected stenosis of the anastomosis. Next slide, please. So this is the imaging right before surgery. You can see distended bowels of loop, some actually measuring up to 5 centimeters in diameter. We have the coronal and the sagittal view. So this prompted emergent surgery. Next slide, please. So now, in the surgery, there were significant adhesions, but there was a sharp object embedded in the abdominal wall protruding into the abdomen. The foreign body was found outside the colon and the small bowel, but there was no contamination noted. The patient did have significant adhesions. Multiple loops of bowel were attached to each other and to the pelvic rim. The bowel was viable, and actually the anastomosis was patent, so that wasn't the cause of the small bowel obstruction. Next slide, please. So the specimen was sent to pathology, and actually right here you can see what we found to be pieces of reactive trabecular bone. So that, next slide, please. So upon finding that in the surgery, retrospectively, we went back to the radiologist and we tried to see if we can identify, or we could identify, the bones on imaging. So right here, we did find it. Now that we knew what to look for, you can see where the arrows are pointing, you can see the foreign body embedded in the abdominal wall. Next slide. So our hypothesis is that these foreign bodies were the source of the initial pneumatosis of the colon with pelvic peritonitis and the subsequent complications and recurrent small bowel obstructions that this patient had endured. The post-op course, the patient had a 7-day hospital stay, which was complicated by constipation. Patient improved and was eventually discharged. Next slide. So that's the case. So now we're looking at what led to the situation. So the big question we're asking is, did the continued irritation of the abdominal cavity by the foreign body play a role in the patient's persistent abdominal pain, the initial pelvic peritonitis, and subsequent GI complications? Next slide. So what is intestinal pneumatosis? Air in the abdomen. What are some causes? We have a long list here, which we will not be going through, but for the intent of this presentation, we'll be talking about comparing if it was caused by ischemia or obstruction. Next slide. Next slide. So causes, like we said, intestinal ischemia or bowel obstruction. However, persistent small bowel obstructions can in turn cause bowel ischemia and pneumatosis. So the debate is to determine if the patient had a perforation of the bowel secondary to the foreign body, or did she have an ischemic event causing the pneumatosis. Now, the patient had no hypotensive episodes or any treatment with vasoconstrictive drugs. And to further rule that out, we did a CT angiogram, which revealed the patent abdominal branch vessels and the superior mesenteric artery had no embolus or thrombus. Next slide. So ischemia, we have two types. We have acute or chronic, and acute could either be caused by an embolus or a thrombus. And like we said, the CT angiogram ruled out any embolic or thrombotic causes. So that's why we're leaning more towards the foreign body being the cause of the symptoms. Next slide, please. So now we're going to be comparing our case to other instances of bowel perforation due to foreign bodies. So here we have the first case of a foreign body that actually caused a perforation while the patient was undergoing a CT scan. The patient came in with symptoms of bowel obstruction, abdominal pain, nausea, vomiting, had neutrophilia on labs, and the CT actually showed a thickened loop with parietal pneumatosis, and a bone segment was detected within the lumen. So in surgery, it was found out that the patient had a goat ossicle, known as a goat bone, in the patient's ilium. Next slide, please. So here you can actually see the arrows pointing to the foreign body embedded in the lumen, and you can see the pathological specimen of the goat bone. Next slide. Thank you. Another case, we have a perforation of the ilium due to an ingestion of a fish bone. So this patient actually had just undergone a coronary intervention, stenting, like 3 days before, came back to the hospital with abdominal pain, chills, fever, abdominal tenderness on exam, and the CT showed the foreign body had penetrated the ileal wall and was causing the symptoms. Next slide, please. So surgery, here you can see the imaging identifies the foreign body, and in surgery you can actually see the bone actually penetrating the ileal wall. Next slide. Third case, we had a small bowel perforation mimicking right lower quadrant appendicitis. Patient came in with symptoms, abdominal pain, nausea, and the pain migrating from the epigastrium to the right lower quadrant, which was pointing towards appendicitis. We actually found a chicken bone in surgery. Next slide. So here you can actually see a pretty sizable chicken bone that had perforated the bowel, which you can see on the right, the picture on the right, with purulent exudate as well. Next slide. Another incidence of bowel and esophageal perforation is actually from metal grill brushes. So we're seeing cases where the brushes used on the barbecue grill, the metal brushes, some of those bristles can actually break off and be ingested. And so in the picture on the left, you can see someone presented with symptoms after a barbecue, and you can actually see the metal wire perforating or protruding through the bowel wall. The picture on the right is a kid who was at a barbecue, presented with symptoms, and there was a metal bristle embedded in the tonsil. So those are some of the cases that we're seeing of complications from bowel perforations with foreign bodies. Next slide, please. So similarities with our case and these cases we just talked about, you see that a common symptom, we're seeing abdominal pain, nausea, vomiting, and you're seeing a distended abdomen upon exam. One difference we would say is in our study or in our case report, the imaging at the start did not point or did not immediately identify the foreign body. So going into the surgery was the only way we could actually see the foreign body. The other cases you can see clear as day on the imaging, there was a foreign body that was very apparent before going into surgery, so they kind of knew what to look for. But it should be noted that in order to detect a foreign body, it's not always easy. The size, the density, the orientation, the part of the bowel that it's embedded in can actually affect your ability to determine if there is a foreign body causing complications. Next slide, please. So in conclusion, foreign body ingestion, like we said, can be difficult to detect. Now, how are some ways that we can actually do better would be, like Dr. Oye was talking about, an extensive history taking. You go back to the source. That's going to tell you the most story or the most information about your patient. Because on talking to the patient after surgery, the patient did report that she eats a lot of chicken bone. So that's something that in retrospect, when you're asking about the history, that's something to ask about diet. It's easy to, the fact that the patient came in with, or the symptoms first developed after orthopedic surgery could have made us lean more towards post-op ileus. But sometimes it's better you need to broaden your perspective or broaden your differential so you're not missing out. And then if the patient has like multiple risk factors like diabetes, if they're elderly, those are things to think about when you're evaluating your patient, because these are things that could have prevented the multiple surgical interventions that the patient underwent. So that's kind of what we have to show you, and I'm going to give the space up to Dr. Stewart to kind of tell you more and add his comments on what we have.
Yes, very good job, engineer. So in this patient, I actually was consulted as a second opinion because this patient had severe abdominal pain with the high white blood count, CT angio to rule out this. Can you hear me? Can you hear me?
Yes.
Okay. So CT angio was done to rule out bowel ischemia, and that was negative, as Itinu said. So the patient was taken in the operating room. I actually took a look, and they had severe pain. Initially, they thought may have had some psychiatric issues because she did have some issues with depression. So she went to the operating room because of evidence of peritonitis. And those are the intraoperative findings that we saw. So when we took her to the operating room, she had significant ischemia. We did a resection, actually Dr. Singh resection, and the planned procedure was to go back and because she was left in discontinuity. So she was reattached, and she was actually discharged. She'd had issues of chronic pain, was sitting in the office by the operating surgeon, but came back again in May, showed these symptoms of this partial small bowel obstruction. She was discharged, treated conservatively, came back again. And what's interesting was after the surgery, we found those chicken bone, and we had the discussion. We never would have thought about a chicken bone as causing the problem or a foreign body even being the cause of the issue. But in retrospect, that's more likely what caused the perforation and the pneumatosis of the bowel to begin with. But because she had had an orthopedic surgery, that wasn't the cause that we were thinking of. So again, the adage of pretty much 80–90% of all diagnoses can be determined by a thorough H&P. That again goes to be shown by this example. And treat patient as if they're a new patient. So even though she came with something else, start off new and fresh as if that person's coming for the first time. And that may have kind of guided us to potentially thinking about a foreign body. But at that time, we had peritonitis, so we were planning on doing the surgery no matter what. But always have that, anything in your differential in terms of what's causing the problem, always start off fresh. So this patient, follow up with her, she actually does have some degree of stenosis at the anastomosis. I actually dilated her and she did well, but my suspicion is that she's probably going to end up having a resection because of the anastomosis is somewhat narrowed. So she's still going to be updated in the future. But this was kind of an interesting case because in retrospect, there was no evidence on the CT scan initially when she came in for a foreign body. And it wasn't until we went back and discovered the foreign body, and we looked at the film, that there was something that looked somewhat suspicious, but because it was so small, it was considered insignificant. And the other thing that's a teaching point in terms of these cases is that every film you do, always look at with the radiologist because you can learn so much. The radiologist only seeing, the only information they have is what you tell them. They don't get to see the patient, they don't get to examine them. You get to see the patient. So you can actually provide information they're not aware of because if you give them a certain history, they can look at something or say, hey, what do you think about this? So that way you can have a more thorough examination, a more thorough differential diagnosis as opposed to them looking at a plain film or looking at an X-ray and coming up with their own diagnoses. So that would be my point of wisdom in terms of any case that you have. Any questions?
Good morning. Yes, my name is Sofakili. I'm actually one point that comes forward, and I've seen it many times when we review cases in the Inspectorate of Health, is what you see that often when the case presents, the focus of radiology is on the main issue, and in many cases, retrospectively, it is noted that actually there was one radiological detail that was actually missed in the first presentation. And in retrospect, and that gives then the way to the complication track that starts. And when you go back to radiology and you say, hey, there's something that we missed. We've seen it several times. Is that something also that's being taken back to the radiologist to, because actually there it is the completeness of the radiological report that hints in the correct direction or may leave something open.
That's very true. So it happens a lot with trauma patients because I do trauma as well. But there are, of course, everyone says hindsight is 2020. And that's why I try to teach the students, and I think everyone in their practice, I don't care what field you go into, if you have a film, especially if it's something that's questionable or significant, review those films. Don't wait for the report to come out. Review those films with the radiologist. We have a process where we're actually, if there's a reading or suspicious or abnormal reading or the findings is inconclusive with the radiologist, we actually go back and call those, we have them review those themselves, and they actually kind of do a PI kind of process with that. Because the whole point isn't to say, hey, you missed something, you were wrong. The whole point is that, hey, we need to look at all these films thoroughly so we don't have problems that show up later on. Because some of these may end up being significant complications that are going to be having bad outcomes for the patient. And then also potential legality. I mean, you can't be 100%, but if we're aware and we're looking at these things and hoping to cut down on our overreads or reads that are inaccurate. But I think one of the big things is we have to take ownership in terms of looking at those films with the radiologist, especially if it's something that's significant. If it's something insignificant that's not gonna make a difference, that's fine. But I think for surgeons, we kind of are worst judges. We're the worst critics. So we wanna make sure we don't miss anything. So we kind of want to make sure that something is gonna, because there's a big difference between something that's insignificant, I can sleep at night, whereas something I'm always questioning whether it's accurate or not. I will look at the film myself and I will monitor that patient throughout the night because I want to make sure that the patient's taken care of, I'm treating them appropriately, and also I can sleep at night. But I think that's one thing we have to do. Don't wait for the report to come 1-2 days later, because if it's something abnormal, you wasted 2 days that you could have treated that symptom. But I think that is something we're looking at. We try to monitor that very closely, because we want to make sure our readings and our diagnoses correspond. Because if we're missing things, or we're missing things that we should have missed, if I can pick something up the radiologist doesn't, then that's a problem.
Thank you very much for your presentation, Dr. Stewart. We look forward to the great work you will continue to do as Avalon's
Ibrahim, we've got one more
question? All right.
Good afternoon, Dr. Stewart. So based on the first case that was presented, the patient came in 5 days post-op and had a bowel resection and had a washout, but there was a leukocytosis and peritonitis. How often do you do the bowel washed out? So in order, especially when the patient has leukocytosis, maybe there could be some infection going on. How often do you guys wash out before closing the resection?
So in this patient, I didn't do the initial surgery. I was consulted to see what my thoughts when I thought this person would go to the operating room. So when they did the surgery, there was contamination. There was ischemia in the bowel that actually was necrotic, and that's why it was resected. So because there was contamination, it's usually not a good idea to actually put them back in continuity, meaning hook them back together, because the problem is the tissue is going to be inflamed. There's a high chance that if you put them together, the anastomosis won't hold. So now you're committing that patient to potentially another surgery or peritonitis because you're going to have a perforation because your anastomosis didn't hold. So this person was a planned return surgery 2 days later. So what they did at the time of initial surgery was basically irrigate the abdomen to try to reduce the nidus infection. So in terms of washouts, those are typically done if you have gross contamination, with the whole point that you're going to come back later on. You're not going to do definitive surgery at that time because you have a high risk of failure. So in terms of washouts, those are commonly done mostly for either perforations or someone like a gunshot wound. Those are done at that time because you have fecal contamination. But usually we come back to with a planned procedure. So your point is, at the time of surgery, you're planning on coming back 24, 48 hours.
No more questions? All right. Thank you, Dr. Stewart.
Oh, one more.
One more?
Thank you, Dr. Stewart. I just wanted to ask about the risk factors. You mentioned a lot of them, and I wanted to ask is the chemicals that are in certain foods, such as processed foods or GMO foods, do they increase a risk factor for foreign body lodging in the intestines due to the chemicals damaging the walls of the intestines?
That's a good question. I honestly don't know the answer, and I'm not sure if there is enough research looking at that, because I think most of the effects we're seeing with GMOs is, honestly, we don't know. I don't think we have enough of a history to make that conclusion. But I would not be surprised because we don't know what altered foods are going to do to the lining of our GI tract. So we may have some disruption of the mucosa, ultimately allowing the wall to be weaker and potentially translocation of bacteria or even objects through the abdominal wall. So my honest answer, I don't know the answer, but it'd be interesting the next 5 to 10 years to see if anyone's done these studies. But that might be potential. But good question.
All right, if there is no more questions, we can give Dr. Stewart a round of applause.
Thank you for the opportunity.
All right, so our next speaker for today is Dr. Balaramia Mecca. Dr. Balaramia currently serves as the chair and professor of the Clinical Skills Department here at Avalon, and he is also a part of the MD3 and 4 faculty.
Please welcome Dr. Balaramia to the stage.
Good morning, everybody. Yes, please. Okay, I'll look at it. Today I'm going to talk about risk factors for atherosclerosis. The definition for atherosclerosis is it is a slow-acting. Atherosclerosis is a slow-reacting chronic inflammatory procedure. It affects the intima of the blood vessels of major arteries like large vessel arteries. Yes, it's a disease of large and medium-sized blood vessels characterized by the formation of atheromas deposited in the intima of the arteries. This particular problem is it exclusively and damages the intima of the arteries. It does not affect the media or adventitia of the arteries. What is the pathogenesis of atheroma? It is a chronic inflammatory process. Actually, the endothelial cells, the intima is the layer which is lined by the endothelial cells overlying the basement membrane. Next to that, the blood is flowing. The blood has got two components, cellular components and plasma components. Cellular components are hematopoietic cells like RBC, WBCs, platelets, and inflammatory cells. Plasma component or the plasma contains proteins, actually the lipids, cholesterol, all these things dissolve in the protein, in the plasma contents. When there is endothelial cell damage is there, the plasma protein of the blood leaks out through the endothelial cells into the intimal layer. When it leaks into the intimal layer, the macrophages engulf this and they oxidize it. So at the same time, the media also releases a factor like platelet-derived growth factor and fibroblast growth factor. They cause, okay, thank you. Can you make it a little closer to me? As I said earlier, this atherosclerosis affects the intimal layer of the blood vessels, large blood vessels, elastic blood vessels, also muscular, medium-sized muscular arteries. This atheroma or atheromatous fatty plaque is the characteristic lesion of atherosclerosis. The earlier lesion of atherosclerosis is a fatty, that is fatty lesions. What are the consequences of these atheromas? Once the atherosclerotic plaque is deposited on the intimal layer, it starts growing towards the lumen, into the lumen. So they protrude into the lumen of the vessels, causing impediment to the blood supply. So this atheroma, as they become bigger and bigger, they may obstruct the blood flow. If there is a partial obstruction to the blood flow, they can cause narrowing of the arteries and produce ischemic changes. Over time, this atherosclerotic plaque becomes much, much bigger, and it gets broken down, and it exposes the subendothelial collagen and forms the atheromatous venous thrombosis, and they completely obstruct the blood flow, causing an infarction lesions. What are the sites of, what are the blood vessels that are involved in the atherosclerotic formation? The blood vessels that are involved are the following descending order: abdominal aorta, coronary arteries, popliteal arteries, descending arteries, also the, next slide please. What are the complications of atherosclerosis? As the atherosclerotic plaque becomes bigger and bigger because of deposition of the lipids and all those things, it causes impediment to the blood supply. So the impediment of the blood supply may be partial, causing ischemic changes. Over time, it completely blocks the blood vessel where it is present, causing infarction changes. For example, like in a myocardial infarction, the coronary artery is blocked. With the coronary artery is blocked, the patient partially is blocked, the patient will be having ischemic heart disease like exertional chest pain and all those things all. And once the atherosclerotic plaque becomes more and bigger, much more bigger, it completely obstructs the coronary artery and causes acute myocardial infarction. This atheromatous plaque can also involve the carotid arteries or middle cerebral arteries, causing the same problem like ischemic attacks like TIA, transient ischemic attacks, or a stroke. It can also affect the atherosclerotic plaque, can also get deposited in the mesenteric arteries, causing small bowel infarctions. Similarly, the atherosclerotic plaque can obstruct the popliteal artery, causing a gangrene or lower extremity of the popliteal artery. Next slide, please. This is the fatty streak. This is the earliest lesion that occurs in atherosclerotic formation. This is not necessary, it should occur in the older age. It starts occurring during the younger age itself, during the teenage period. So this is the first, there is the earliest lesion of the atherosclerosis, the fatty streak. This fatty streak is almost completely flushed out with the endothelial layer. There is no obstruction to the blood flow. Here, the foamy macrophages is following the insult to the, following injury to the alveoli, endothelial cells, the plasma proteins of the blood that is flowing into the lumen, it leaks out into the intimal layer, and the macrophages engulf them and form foamy macrophages. This is another important pathognomonic finding in the fatty streak. So here the lipids that get into the macrophages, they get oxidized, they become more atheromatic. Actually, it is a protective lesion, but as more and more of endothelial cells are damaged, more and more of plasma proteins leak out from the flowing bloodstream in the blood vessel and cause an atherosclerotic plaque on the intimal layer. So fatty streak is the earliest layer, and fibrofatic atheroma is the classic feature of the atheromatous lesions. Next slide, please. This is the sequence of events that are occurring right from the beginning of the normal coronary artery. This is the normal coronary artery. The innermost layer is the intimal layer. The media is the middle layer. Adventitious, it is completely normal. So normal coronary artery with no atherosclerosis and a widely patent lumen that can carry much blood as the myocardium requires. Here, the atherosclerotic plaque started forming following the damage of the endothelial cells. The plasma proteins leaks into the intimal layer and they form atheromatous plaque. And the atheromatous plaque is becoming bigger and bigger, and almost 2/3 of the blood vessel is completely blocked by the atheromatous plaque, leaving only 1/3 patent. So this patient, with this patient will be having ischemic symptoms, like for example in coronary artery occlusion like this, you'll be having exertional dyspnea or exertional syncopal attacks. This is the first one, normal. This is the formation of the atherosclerotic plaque, occluding almost 2/3. Next slide, please. The third one is the atheromatous plaque gets ruptured and exposes the endothelial collagen, and tissue thromboplastin is released, and it activates the coagulation cascade and forms the formation of the thrombus, and what little space was left behind, it is completely occluded by the venous thrombus of the atherosclerotic as well as the atherosclerotic plaque material. Now there is a complete occlusion of the coronary artery causing acute myocardial infarction or irreversible damage. Next slide, please. What are the signs and symptoms of the atherosclerosis? It depends upon the occlusion of the blood vessels. As the blood vessel is being disturbed, being blocked by the growing atherosclerotic in the lumen, if it is a partial block, you'll be having ischemic changes, or if it is a complete block, you'll be having infarction changes. Depending upon the artery also, the symptoms depends upon the artery where it is atherosclerosis being formed. For example, if it is in the coronary artery, if there is a partial obstruction with atherosclerotic plaque, it causes angina pectoris or ischemic heart disease. Or if there is a complete occlusion, it can cause acute myocardial infarction. The same process, if atherosclerotic plaque deposition occurs in the carotid artery or middle cerebral artery, you can have cerebral infarctions. If similarly, the atherosclerotic plaque deposition occurs in the popliteal artery, if it's a partial obstruction, it can cause vasculitis, the peripheral vasculitis. If it is complete occlusion, you can develop gangrene of the lower extremities. Next slide, please. So what is the complication of atherosclerosis? It depends upon the occlusion of the blood vessels into which the atherosclerotic plaque is growing. If there is a partial occlusion, if actually this is the atherosclerotic plaque, this is the internal elastic lamina, this is the media. So here it is a disease of entirely, it is intimal layer. So this the atherosclerotic plaque is growing towards the lumen. So but in this case, it is almost 50% of the lumen of the atherosclerotic plaque is obstructed. There is partial obstruction is there. So chronic narrowing of the vessel. So there is a progressive reduction of the blood flow to the tissues. It can cause chronic ischemia. For example, if it happens in the renal artery, the renal artery stenosis. If there is renal artery stenosis renal artery is blocked with atherosclerotic plaque, the affected renal kidney undergoes atrophy. Later, because of hypoperfusion of the kidney, the patient secretes renin. This activates the renin-angiotensin mechanism. Finally, it develops the renal hypertension or renal vascular hypertension. Similarly, in conditions like popliteal artery, it can cause, especially in diabetes mellitus, it can cause peripheral vascular disease. Next slide, please. So these are the complications of atherosclerosis, mainly due to narrowing of the lumens of the lower limb vessels. It can cause gangrene of lower legs. Due to atherosclerosis of the popliteal artery, there also can cause impotence due to occlusion of the iliac arteries. Next slide, please. Okay, now let us talk about the risk factors for atherosclerosis. It is a common term. The symptoms and signs depends upon which blood vessel is affected. Otherwise, the risk factor are uniform to what atherosclerotic plaques. Whether atherosclerotic plaque occurs in the coronary artery, or occurs in the carotid artery, or in the popliteal artery, all the risk factors are same for everything. What are the major factors? These are classified into non-modifiable. They cannot be corrected. They are all fixed. Nothing can change it. For example, like age. After 45, atherosclerosis is very common. Male gender. It is not another important cause for atherosclerotic formation. Family history. Age-wise, it is 45. After 45, it is the age when the atherosclerotic plaque starts forming. Whereas in male gender, second case is male gender. This is very important to know because this incidence of ischemic heart disease, myocardial infarction, sudden cardiac death, and strokes are rather uncommon in female of childbearing age. Up to menopause, they don't develop the problems of ischemic heart disease or myocardial infarction or strokes. This is as long as they're menstruating, these incidents are very rare. This is because of endogenous estrogen. This protects them. This protects not only the cardiac problems, even bone problems like osteoporosis also rather uncommon in female of childbearing age till they attain menopause, because it is the estrogen that is being secreted during this particular period, childbearing period, is highly cardioprotective as well as bone protective. That is the reason the atherosclerotic formation is more common in males after 45. It is more common as they grow much older. These was three non-modifiable factors. What is the family history? You got whenever a patient comes to you with the atherosclerotic chest pain or atherosclerotic stroke, you got to ask the family history. The family history is a premature cardiac death like myocardial infarction, or sudden cardiac death premature in the first degree relatives, or premature history of strokes in the earlier part of in the younger brothers, all those things. These are the three non-modifiable which cannot be corrected. Age-wise, it is 45. So externally, we can correct our age. First, old people can do cosmetic surgeries and plastic surgeries and look younger, but still they are what they are age. So age, male gender, family history, these are the non-modifiable factors. Second is modifiable factor. This can be controlled. Once they are controlled, the risk can be reduced. So atherosclerotic plaque formation is much reduced. So these modifiable factors are hyperlipidemia, hypertension, cigarette smoking, diabetes. Other minor factors are hyperhomocystinemia, C-reactive protein, obesity, physical inactivity, stress, and also high carbohydrate diet. We'll talk about these factors one by one. Next slide, please. Non-modifiable factors. There are three in number. Number one is age. After 45, it is quite common. The risk increases more and more as they become much older, because during the aging process they may encounter other diseases like diabetes, hypertension, or habits like smoking, alcohol consumption. This adds some fuel to the fire. So age is the most important overall risk factors. Male is after 45 and more risky as they grow older. In case of female, 55, because the reason I told you earlier, because 55 is supposed to be the age when they attain menopause. So the endogenous estrogen that is being secreted during the normal reproductive phase, it is highly helpful. It is a cardioprotective as well as bone protective. Family history of premature cardiovascular death or myocardial infarction. Here it is mostly because of familial hypercholesterolemia, which are genetic disorder which cannot be corrected, so they come under the non-modifiable factors. So males are prone to atherosclerosis than the females. I have already explained these things because this atherosclerosis associated complication is less common in premenopausal women because of the presence of estrogen. Estrogen increases their high density lipoproteins to higher level. They take care of it. So once they attain the menopause, the estrogen level goes down, then the risk becomes more. So incidence of myocardial infarction is the same in males and females in 7th or 8th decade of life. Family history, this is because of familial hypercholesterolemia, which cannot be corrected, which comes under the non-modifiable factor. These are the 3 non-modifiable factors. Next slide, please. These are the minor causes for the atherosclerosis. Hyperhomocystinemia. Commonest cause of hyperhomocystinemia in developed countries is due to folate deficiency, which is due to chronic alcoholics. In chronic alcoholics, there are 2 vitamin deficiencies very common, folate as well as B1, thiamine hydrochloride. Once the folate or B1 is deficient, B1 deficiency is rather uncommon because the B1 is stored in the liver for storage for so many years. So folate deficiency is very common, which can increase your homocysteine. How does it help? How does it produce atherosclerosis? Homocysteine is one of the 2 important, like one homocystinemia and also antibody antilipid syndrome. These 2 are notorious for causing arterial thrombosis as well as the venous thrombosis. So they cause that arterial thrombosis, especially the coronary arteries, and leakage of the atherosclerotic plaque. Increased incidence of vascular disease. Elevated, these are minor factors: physical inactivity, stress, high carbohydrate diet, chlamydia, pneumonia infections, all these are minor factors. Both correlate with the increased risk of ischemic heart disease. Next slide, please. Potentially modifiable. Let us talk about the non-modifiable factors: hyperlipidemia, hypertension, cigarette smoking, diabetes mellitus. Let us start with the cigarette smoking. Cigarette smoking, as we already know, it contains more of carcinogens. Carcinogens, about 69 carcinogens, well documented. There are about 4,000 chemical toxins. These are the culprits causing endothelial damage. In atherosclerosis, the problem that starts is endothelial damage because it is the most intimal layer. It is closer to the blood that is flowing into the lumen. So when there is chemical toxins damages the endothelial cells, the plasma proteins leak out and the problem starts. Second is hyperlipidemia. Hyperlipidemia, whenever there is increased cholesterol. Whenever we hear about cholesterol, we think it is bad. We need cholesterol in adequate concentration, which is important for our body. So cholesterol is important for the cell membrane integrity. So cholesterol is normally very essential for this as a precursor molecule for the synthesis of bile acids as well as steroids. So cholesterol is important also for the conversion of 7-dehydrocholesterol in the skin to active vitamin D. So the cholesterol is very, very essential in our body. Only increased cholesterol only is bad. There are the LDL cholesterol. It carries the cholesterol from the liver and distributes it to the peripheral tissues. HDL cholesterol is otherwise called a good cholesterol or a healthy cholesterol. The main function of healthy cholesterol is it hunts for the cholesterol, it hunts for the excessive cholesterol in the body, it brings it back to the liver for disposal and for excretion. So increased level of high cholesterol is a negative risk factor for atherosclerosis. So increased levels associated with the low risk of atherosclerosis. So high density lipoproteins more than 60 milligrams is the negative risk factors for coronary artery disease. Having understood the importance of elevated HDL, don't we think that it is important for us to find out any measures to increase our endogenous higher density lipoproteins? Is there any method by which we increase our endogenous higher density lipoproteins? Yes, there are few are there. Number one is, it all starts with capital E. For example, like first E starts with the physical exercise. Go to the gym, do the heavy exercises, muscle stretching exercises, it automatically increases your HDL level. Another thing I want to tell the young students, the young males, when they go to the gym and does the workout, it not only increases your endogenous HDL, it also increases your testosterone. So you get 2 in 1 by doing the physical exercises. Here we are talking about discussing more of the endogenous insulin, endogenous HDL increase. Second is, second is called ethyl alcohol. Second is ethyl alcohol. This also increases your endogenous HDL. And third is estrogen available in exogenous estrogen. It also increases the HDL. This is usually prescribed to post-menopausal women. What this hypertension is one of the non-modifiable factor. Once the hypertension comes, it accelerates the atherosclerosis. Again, it causes endothelial cell damage. So the blood pressure control is very important. Cigarette smoking, we already discussed, it enhances the atherosclerosis by damaging the endothelial cells. So incidence of coronary, that's myocardial infarction, is 3 times more common than in the non-smokers. Smoking lowers the HDL, that is another negative risk factor. Cessation of smoking reduces the risk. Next slide, please. Diabetes mellitus. Diabetes mellitus is one particular notorious disease. Once it gets in, it invites all the diseases. Once the diabetes mellitus is present, it gives rise to the secondary hyperlipidemias. So secondary hyperlipidemias, again, it also induces hyperlipidemia, which enhances atherosclerosis. So incidence of myocardial infarction, again, 3 times more than the non-diabetic. Also in diabetes, you get a painless infarction, which is about 18%. There is also increased risk of stroke in diabetes because of the carotid atherosclerosis. Increased risk of atherosclerosis also because diabetes is notorious for producing popliteal artery atherosclerosis. Popliteal artery is the next smallest artery compared to coronary artery. So the develop gangrene of the lower limbs. Next slide, please. So having talked about the diabetes mellitus, what are the other effects, other hard facts of the diabetes mellitus? It has been estimated, it has been well noted, diabetes mellitus is the #1 cause of blindness in the United States. Because as we know, the diabetes mellitus interfaces the sorbitol polyolip pathway, and it causes osmotic damage to the retina and as well as the blood vessels, causing blindness. So it is #1 cause of blindness in the USA. Similarly, diabetes is the #1 cause of non-traumatic amputation of lower limbs in USA because it causes atherosclerotic plaque in the popliteal artery. The popliteal artery gets completely blocked, developing gangrene in the lower limbs. So these people in developed countries, this is the #1 cause for the non-traumatic amputation of the lower limbs. So diabetes plays an important role here. Also, diabetes causes peripheral neuropathy when partially there is obstruction to the popliteal artery. And also diabetes mellitus also causes chronic renal failure in USA. And we are talking about the smoking earlier. Smoking is the #1 cause of preventable premature death in United States. Second is obesity is also, which is also another risk factor for the atherosclerosis. It is also the second cause of preventable premature death. Alcoholism is the #3 cause of preventable premature death in United States. So how are we to prevent this? Quit smoking. Smoking is bad for heart health. Control high blood pressure, high cholesterol, and control your diabetes. Exercise often. Healthy weight maintenance is very important. Eat low-fat, low-salt diet. Reduce and manage stress. Next slide, please. I want to thank my friend, my colleague, Dr. Kumar, for his help in preparing this PowerPoints. And I wish you all healthy, energetic, and productive life. Take care. Thank you. Yeah, thank you. Thank you. Any questions, please?
We'll do questions after because we're actually cutting into lunch.
Okay, you want me to wait?
We can do questions after.
Yeah.
Yes. Thank you, Dr. Marwaha. Very fantastic. I've heard your lecture before, but not this detailed, so I appreciate it. 10 years or more ago, people started taking statins. It's very well known. Probably everybody over 40 is taking a statin in many parts of the world, certainly the United States. Are there any conclusions about reversing? You know, once it's started, you know, is it going to go to a clot, thrombosis, and so forth? But once the atherosclerosis has begun, are there any studies about whether statins reverse in any way atherosclerosis? Statins like atorvastatin, pravastatin, so forth. Statins. I'm just curious. Are there any studies whether it has shown? I know it decreases mortality, but does it?
Statin drugs.
Statins. S-T-A-T-I-N-S. Pravastatin, atorvastatin, pravastatin. Am I making any sense to you?
I am not quite sure about it, but there are some drugs which are available which reduces.
I'm sorry, I didn't hear. It's a common usage. People, internists will give people statins, assign statins, and that reduces their LDLs and so forth. I'm not sure if it ever reduces atherosclerosis. It's sort of the new track.
Okay.
If you follow what I'm saying. Thank you.
Thank you. Thank you very much.
All right, thank you everyone. We will now be going for our lunch break. So we do ask everyone to pay attention to the poster presentations outside as well. So whoever is going to be presenting those, they can set up.
And please don't forget to come back and make sure that you check in at the front desk to get your attendance after lunch as well.
Thank you.
stuff over here. Oh, what's the timer for?
15 minutes, right?
You guys take 15 seconds.
Thank you.
Might need to scroll down.
Is it back on? Oh, yes, definitely on.
Oh, wait, hold on. I didn't see it. Scroll down. This is all new. This is all new.
Oh, because you're going to have to improvise.
Hold on, let me read it.
I like
haven't
when
seen it before.
You can be surprised. You should crack a joke.
Probably will.
Huh?
I probably will.
Really?
Mhm.
You should.
Like Dr. Suma has been involved in medical education and is the best pathology teacher we have. See, that's funny because she's the only pathology teacher we have.
Yo, can you please say that?
Did you have Dr.
Sarah! Sarah!
Dr. Suma is presently professor of pathology at whatever.
Who's off Dr. Suma? Who's off Dr. Suma?
Should I wait? No, wait. Good afternoon, everyone. I hope that you all enjoyed your lunch break. We're going to get right back into it with our next speaker for today, which is Dr. Suma Alluri. Dr. Suma is presently the professor of pathology here at Avalon University School of Medicine.
Dr. Suma has been involved in medical education and teaching pathology since 2006. He also previously served as a medical officer in the Indian Army. Today, Dr. Suma will be discussing MPV by platelet count ratio, the role in differentiating iron and non-iron deficiency anemias. Please welcome Dr. Suma to the stage.
Good afternoon. So I am a little nervous today because I encouraged everybody ask questions, and now I am the speaker. Okay? So maybe this session doesn't need many questions. Good afternoon. Thank you for the kind introduction. And before I start my first slide, once the slide comes up, you'll realize that I have selfishly written one name, that is mine, and there is no research without a team. So I want to talk about the team first, which is FAIR. And while I talk about the team, I request Dr. Lambo not to consider this time as my speaking time. So when this research came on hand, I was an assistant professor, and I was actually very eager to start my own research, but I needed a mentor. And the mentor who came to my mind was my external examiner, who I met only for one day when I took the pathology exam. I knew her just for one day. But I was so much impressed, and I really admired the way she taught us during the exam. So the exam itself was like an education for us. So her name is Dr. Asha, and she was my mentor for this study. And I also want to tell you that I am not as studious as I may appear to you. I didn't do this research because I'm interested in research. There was a brochure sent around by a medical company called Horeba, which said that if you make a hypothesis based on hematology analyzers, I'm repeating, a research based on hematology analyzers, the company which makes the analyzer would sponsor your trip to CMC Vellore. So it was the Indian Airlines flight ticket that inspired me to do this research. So it was the free trip which was behind the push to do this research. Yeah, there is always a selfish reason. But when I contacted my mentor, she told me that whatever you're working on should be useful to the healthcare society. Like, it should be useful for the doctor, it should be useful for the patient. Otherwise, don't go ahead and do this particular research. So then when I framed this hypothesis, I was working on mean platelet volume and platelet count. These are platelet indices. Now I have more than 6 studies going on parallelly about platelet indices. And I'm very proud to say that even today, Dr. Asha, who is still in touch with me, who is more than 85 years old now, she still guides me in my studies. So what is it about this ratio, and how is Avalon associated with this study? When I wanted to approach the research committee to do a study, I was told that I need to first have a proposal made and I need to submit it. So I started looking for students, and you all know that the coordinator is Rohini, and she was the one who coordinated for me with students who were interested to join my study. So the first student who approached me was a student from MD3 at that time, and her name was Daman Dhillon. The next one in the team is Johnson Ingwe. The next 2 doctors are from Ludhiana, Dr. Vinod Sharma, Dr. Durgesh Sharma, and of course myself. This is our team. Right now, the students who are now struggling in MD5 or they are preparing for step 1, I now invited another clinical student to join this study. His name is Cristo Lamprakos. He is now doing his vascular surgery rotation. We just saw him for a few seconds when the vascular surgeon spoke today. He came to tell us that he will answer the questions later. So he's the new addition to this team. So how our team works? We receive the data from this clinic in Ludhiana, and there is a lab and clinic, and the clinic has patients who are getting treated for anemia, and we approach them to give Avalon University team their data. And the data processing was based on the study I did many years ago, and this is actually like a pilot study, like the data I have, which I was working in a very small clinic in a very small town called Eluru in Andhra Pradesh. So over there, we had a small 3-part hematology analyzer. A hematology analyzer counts RBCs, counts platelets, it counts the WBCs. And it also gives us values about the measurement or the size of these cells. So the analyzer is a mechanical instrument. It cannot work like a human. It cannot tell us a lot about morphology, but it tells us about the size and the number. I'm sorry if I'm going into the details medical students know, because I want my audience to follow me. So can I have the second slide, please? Yeah. So when we started working on this, we wanted to know what exactly is the correlation between anemia and platelet indices. So whenever we had this, any study being done, the first thing, of course, you're going to review literature. So when I went through literature, I saw that anemias, any anemia where there is a reduction of RBC count, there is a change in another formed element, that is the platelet. So we wanted to monitor these changes. What are these changes? And I tried to tell my team that the changes are very significant. So significant that you can see that the reference given here, the journal Pediatrics published, that children who were having anemias were frequently prone to getting thrombosis. So that caught my attention. How is anemia related to thrombosis? Is the platelet getting activated due to anemia? Then I started reading about this. And when I read about it, I saw that the mechanism of thrombosis, why does thrombosis occur in anemia, is not known. It's not mentioned in medical textbooks. It is not considered a threat. Anemia is not considered a threat to thrombosis, but during anemia, there is thrombocytosis. So then our objective was ready. How are the platelet indices changing in anemia? But then we had to choose what is the platelet indices that I'm going to check. Am I going to check mean platelet volume? Am I going to check platelet count? Am I going to check the ratio of this? So then we started to read, or the main principal investigator has to read, and they need to find out what exactly is to be studied. So then, next slide please. Then I looked at a study which was in a journal called Platelets, and this is by Young et al. What they did, they studied two groups of people. One group of people had iron deficiency anemia, and the other group of people had the other anemias, all the other anemias put together, but not iron deficiency. To come to this conclusion, they had a lot of resources. Of course, you need money to do research, and that money was provided for classifying these patients. They did TIBC, they checked serum transferrin, and they checked what is the iron binding capacity in this individual, what is the mean corpuscular volume of the RBC. Based on that, they made these two categories. Of course, where I was working, we did not have the facilities to do all these tests. So we decided the inclusion criteria based on our hematology analyzer. So on our analyzer, we could see hemoglobin that is less than 11, and we could see mean corpuscular volume that is less than 80 was iron deficiency anemia, more than 80 is non-iron deficiency anemia. That's how we made our criteria. We also decided that we will not take patients who are under the influence of drugs which are activating a platelet. We didn't take patients who are having inflammations, because inflammation can also activate platelets. So whatever we read about platelets, we tried to include in our inclusion criteria. Except money, we had everything in our inclusion criteria. So we had to look for ways and means to use the analyzer we had. We had only one analyzer in the lab. Of course, they had me. I used to study the peripheral smear and tell them, is it microcytic or macrocytic? So I confirm by morphology. So these were my inclusion criteria in contrast to the study which I read. Then we went on and collected, and I also had a colleague there, Dr. Mahati, who right now is working in St. Lucia. She was also there who supported me in the initial pilot study. And we had iron deficiency anemia. We had some 70 cases, non-iron deficiency, 102 cases. And then Dr. Asha helped us with 100 normal individuals. So we had controls. So we had one group of controls. One was non-iron deficiency anemia, the other was iron deficiency anemia. So we had a statistician to help us who worked with a software called SSPS. It is also called PSSS, that is the package of statistics of social sciences. So this, we had a specialist who did it for us. So I am not trained like you because I didn't have Dr. Lambo as my teacher. I didn't do all the research you do in MD3, MD4. I really appreciate what you guys do. So now when we wanted to compare this MPV, I have two groups here. You can very easily follow the graph. Even if you don't like it, you will follow it very easily because you can see the yellow and the blue line. Can you please show us the next slide? There are two lines there which are almost following the same pattern. Very few places there is a difference. It could be based on men and women, which we did not categorize. It could be based on children and adults. It could be based on women who are premenopausal and postmenopausal. There are many conditions here. So, but generally, the graph was not helpful in differentiating these groups. So I went for the next, please show me the next. So I went for the next level. We said, okay, let us look at two indices being calculated. A calculation of an indices is called a ratio, and it is also generated automatically by an analyzer. Because an analyzer can tell us what is mean platelet volume. The analyzer can tell us what is the platelet count. So analyzer just divides A divided by B, and it gives us a value. So this was the value I was looking at. So this value, when I put it, you can see the dot plots. There are two dot plots here. And the first blue dot plot has got maximum red dots at one value. And there is also black dots seen there. And whenever you see black dots, please remember those were our controls. So the controls were having a value which is very close to the values which are given by our cohort. And this cohort is iron deficiency anemia. So iron deficiency anemia values are correlating with the values in normal individuals. That is the first graph. In the second graph, the background of orange, you can see that there are a lot of, the same slide please. There are a lot of dots, black ones, which are dispersed away from the main line. You can see a lot of disperse of dots. So this dot plot is telling me that all the non-iron deficiency anemias, there is a deviation. It is not the same as in iron deficiency anemia. So I almost felt as if I am Einstein, let me tell you. I thought I reached some breakthrough. But when we saw only the mean ratio, I didn't see such a big variation in each value because the values in a dot plot were difficult to assess. And please show me the next slide. So this is just a bar diagram, a horizontal diagram, where the length is proportionate to the value. So you can see that the value of IDA, that is the last one, is the shortest, and the value of the non-IDA is the longest. So there is a very big difference when you consider only the mean value. So when I considered only the mean value, I'm able to see a very big difference. But if I consider individual values, the difference was very less. So because of this, the p-value we calculated could not be less than 0.05. So as you know, when the p-value is less, the study has no significance. So I was quite sure that I'm not going to be given this air ticket to fly to CMC Vellore by the time my results were out. But then I contacted the HOD of hematology at CMC Vellore. It is one of the top ranking universities in India for hematology. So I contacted him and sent my study. The next day I had my tickets. He told me p-value does not decide whether you come here or not. The objective of your study decides whether you come here or not. You told us that there is a big difference between iron deficiency anemia and non-iron deficiency anemia. So there the tickets were there, and then I packed and I thought it's a great holiday to go. But little did I know that in the audience, there are going to be pathologists more senior than me. They're going to ask me questions. Yes? Just now, as I'm fearing that you will ask me questions after this presentation. Next slide, please. So what exactly did I find out? I found that there is a difference between these two groups. That means the value is twice higher in non-iron deficiency anemia than the iron deficiency anemia. So if I have a simple 3-part analyzer, which is not an expensive equipment, if I run a small lab with that equipment, I need not do serum iron transferrin. I don't have to do iron binding studies. I don't have to do bone marrow biopsy. Just by spending 2 rupees, 80 rupees is $1. Yeah, someone will be wondering, what is she talking? I'm talking about how much it costs to do this test. Just by spending 2 rupees, I can tell whether this individual is having iron deficiency anemia or non-iron deficiency anemia. That was what was the major breakthrough. The second aspect is that this ratio displayed an outstanding performance in distinguishing these two types. So we can expect that this panel can be used later somewhere as a biochemical marker. It is the same finding few other studies had, the same study as Young et al. But let me tell you some drawbacks of this study. Let me tell you where I went wrong. The problem with this study is that in iron deficiency anemia, the platelets have a biphasic response. If a person has moderate iron deficiency anemia, there is reactive thrombocytosis. If a person has severe iron deficiency anemia, there is thrombocytopenia. So in one situation, they are having thrombocytosis. In another situation, they are having thrombocytopenia. So this was the challenge in this study. What is the problem? What if we have thrombocytosis or thrombocytopenia? How does it matter? I'll tell you how it matters. If there are more platelets in the blood, generally the size becomes smaller. So the mean platelet volume is going to be less. And when there are less number of platelets, by nature, bone marrow tries to make larger platelets. So that is, mean platelet volume is becoming larger, higher in value. So that is the reason we needed now 2 groups. We need a group which has severe IDA and moderate IDA. So that is the reason I am continuing this study with Avalon students. And now we have taken all the data, more than 100 patients have approached that clinic in Ludhiana, and they have agreed to share this data. And I think we are now at 300 iron deficiency anemia cases where we will be able to decide this difference. And we will also be able to know the relationship between platelet volume, platelet counts, and iron deficiency anemia, considering all the drawbacks of the age factor and the gender factor also. So we have included males and females as cohorts. We have included age as cohort. We are also including the severe and most moderate and severe iron deficiency anemias. So this paper is, we are hoping that it will be accepted this year. We are working towards completion of this, and I hope by maybe 1 or 2 symposiums, maybe we will have the final published paper here to be presented. So the conclusion of my pilot study is that this ratio, mean platelet volume and platelet count ratio, next slide, yeah, thank you. So this ratio is going to be higher in non-IDA patients than in IDA patients. The utility is questionable because our p-value was more than 0.05. So the further data collection and studies should elucidate mechanism and also the difference of MPV, how platelet count works on these different anemias. We have to work on this. So that is the goal of our study. And these are my references. Next slide, please. And we have many more references which we will add because my study is dated back to 2018. And now with Avalon accepting the study in 2020, we started this during the pandemic. So now 2020 to 2023, we are concluding this study. And I'm hoping that this year we are going to publish this. I'm very grateful to Dr. Lambo to have allowed, at the fetal status, you allowed my paper to be presented here. Thank you so much. And I really want questions. Last slide. I'm not going home if nobody asks a question. Is that okay, Dr. Lambo? Is that okay? He agreed. You know, they will agree with you more than me. Yeah. So I tried to explain, yes, there is a hand raised there. Thank you so much. Thank you for making sure I go home.
Thank you very much for that wonderful presentation. It's the first time that I've heard a professional present such a research, so I appreciate that. So you mentioned about when you were doing the differences, you came to a point where you realized that there was a difference between severe and moderate anemia. So what was that criteria like? What numbers did you look to differentiate the two?
It was hemoglobin less than 7 and mean corpuscular volume less than 70 and hemoglobin less than 7. And if the hemoglobin was less than 11, there was a difference in these two groups. So I will tell you why it is difficult to find this second group. Moment hemoglobin is less than 7, no doctor is going to wait. He's going to give a transfusion. So this cohort is difficult to find. So we won't have them walking to a clinic. They will be usually hospitalized. And they would have already received a transfusion, or they would already be getting some supplements. So that is the reason we were not able to get too many patients with that low hemoglobin. That is why when we found a lot of studies, kind of underlining this, we decided to collect more data. So our aim is now to go for at least 600 patients, and then we start working on the graphs again and to see how the p-value is going to change.
So the data you worked with for the lower deficiency anemia, getting the patients who have hemoglobin below 7 is a big challenge, like you said. So going forward, what are you going to do to at least increase the number of those patients so you can get the differences?
So what we're planning to do is that this doctor who is running the clinic, this is a outpatient clinic. He has no inpatients. So what we did is that we have gone into the retrospective data he has. We are trying to see if any of his patients were hospitalized. If they were hospitalized, during their hospitalization, did they go into this level? We go and check the records he has with him. And we are checking and we are adding it as a retrospective data and seeing what was their platelet count when the hemoglobin was less than 7. And we will see how many such patients we can gather in our data, because our data is only from one source. We cannot go to another source. We have to continue at the same clinic. So we are going to review the same patients we have, find out if in the past did they have a low hemoglobin, did they go down to 6? And if they have their blood value at that time, if I can get their records at that time, what was their platelet count?
Okay, and the last question, in terms of how much that data could be applicable to a wide range of people, the demographics of the patients that you're getting in the study, how comparable is it to the general population? So in terms of when you finish doing the study, the results that you can obtain from the study, how far do you think it will be applicable to the general population in other areas of the world?
Yeah, very good question. So for my team, if we are able to divide this into two groups, one is a male population, the other is female population. The most common cause of iron deficiency anemia in females is menorrhagia. The most common cause of iron deficiency anemia in males is GI cancer. So these two groups are going to benefit the most from my study. That is the most, GI cancer is the most common cancer, say, at least in US or the Western countries. And in all countries where spiced food and pickled food is used. And menorrhagia and iron deficiency and anemia in females is a very big disease in almost every country in the world. It's the most common cause of anemia in the world. So I am thinking that these two groups are going to benefit most from my study.
All right, thank you very much. Appreciate it.
Yeah. Thank you so much, and I really appreciate, yeah, sir, please. Really appreciate your questions. Thank you.
Yes, one of the tricky things is always the p-value. P-value is always an issue.
Yeah.
And one of the things in p-values, what you get in p-value, it's depending on the contrast in your data. And your contrast in your data, it regards actually which is the extreme high group and the extreme low group. There you have the highest contrast. So the question is, because you work with two groups, if you have more data, it would be maybe, would it be an idea to work with quartiles in the sense that the highest hemoglobin and
Yes.
the lowest near 7, but still the lowest, and then collapse?
Yes, sir.
And that way you get contrast between the highest group and group, because it might be that because of the around 11, it's very, you might have classification issues
sure, sir,
and
sure.
inaccuracies in
Definitely, sir.
performance, that if you take the extremist group and that there you will have more distinction and more statistical power to determine, but maybe it might be that you might
Definitely,
have
sir.
more data for it, because then with
Yes.
600 cases you would have I think it's 150, and then 300 in the middle. But if you contrast the 150 upper with the 150 lower, if then nothing happens, then probably the story is over. But it might be that the difference is there, because then you don't have the misclassifications.
Yes, we are hoping that there will be a difference with a larger cohort.
Dr. Suma, thank you very much for your presentation. I think apart from the issue of statistical significance using p-value, I don't think that's a problem. At the end of the day, you might want to think about the clinical utility, of your research.
Yes.
Minimally clinical significant effect in the
Yes.
population.
Yes.
It matters more than statistical significance, and I think you are getting there.
Yes.
By the time you power your study, you'll be able to see that distinction between statistical significance and clinically. One thing I'd like to know, what is going to be the goal of your research at the end? How will people benefit from it?
Actually, this hematology analyzer, which started this sponsoring my pilot study, sir, they are intending to add this as one of the parameters. Like you can get the ME ratio, you can get the MPV by platelet count ratio automatically in the analyzer if it has a clinical significance. That was the interest of the company, the Horiba International, which had sponsored my trip and allowed me to present this study at CMC Vellore. That was actually the significance of this, goal of this study.
Very good.
Yeah, thank you so much, sir. And it is also a lesson to me, because we were disappointed seeing the p-value. As Dr. Lambo said, I was told that the clinical significance is sometimes overrules the p-value. Thank you so much. Thank you for your patience, and I really appreciate this opportunity.
All right, thank you very much, Dr. Suma. Our next speaker is Cristo Lamprakos. He is a third-year medical student here at Avalon and is currently completing his clinicals in Beckley, West Virginia. He has served on multiple committees at Avalon, including the Admissions Committee, Self-Study Accreditation Committee, and our Research Committee. Prior to medical school, he received his degree in History and Pre-Medical Sciences at York University.
He also received his diploma in nursing assistance with a specialization in Alzheimer's and dementia care. He received further training at hospice and palliative care facilities for 5 years prior to beginning medical school. His primary areas of interest have been inpatient medicine as well as general and endovascular surgery. Today, he will be presenting a case outlining possible complications in endovascular surgery. Please give him a warm welcome.
Thank you, my colleagues. Thank you for the introduction. I will be presenting a case on some complications in endovascular surgery. Okay, so the title of this paper is going to be Failed Retrograde Femoral Approach with a Completed Occlusion Left Common Iliac Prompting a Femoral Bypass. Okay. So let's go to the next slide. Perfect. So I hope you guys paid attention when Dr. Balaramia, a good friend of mine and one of the best professors I've had, including Dr. Suma and many of them, but I hope you guys paid attention because this is what the consequences of atherosclerotic disease, okay? What happens when a patient presents with peripheral artery disease? What do we see? About 10 to 20% of males over the age of 60 will develop peripheral artery disease. On physical exam, we are looking at the 6 Ps, okay? What are the 6 Ps of peripheral artery disease? That's going to be pallor, pain, paresthesia, so they're going to be paralyzed, they can't really move, okay? The paralysis, pulselessness, and polokilothermia. What is that? It's a Greek word for coldness. Your feet will be cold. Of these symptoms, what are the worst? What shows us we may need surgical intervention? That's going to be pain, pulselessness. So how do we determine that, right? How do we determine that? What are the causing factors? We know diabetes, smoking, uncontrolled hypertension. In that order, those are the risk factors, okay? Let's go next slide. Okay, let's discuss our patient. Okay. Patient presented with a history of total abdominal colectomy. Okay, the patient has a history of diabetes, smoking, and hypertension. Okay. Wow. The patient was also hypotensive. And due to hypotensive, in the ICU, they were put on vasopressors. And we'll discuss the complications of vasopressors towards the end of the presentation. We were summoned to the ICU because pulselessness was detected on the leg. Okay, this was ischemia, and we could not detect any pulses on Doppler. Now, what is a Doppler? Doppler is a sort of a microphone, sort of an ultrasound machine that kind of picks up the sound waves. So you hear the pulse. As the pulse is coming, it will make a swoosh sound. This is kind of what you're looking for, and we couldn't detect it. So we needed to take the patient down for surgery. Okay. Now these marks, I put these marks down. These are the places where we listen for the pulses. Okay. So now, what's our next step? We've identified there's no pulses. What is our next step? Our next step, let's go to the next slide. We are going to send them for CT with runoff. What is that? We're going to inject dye, do a CT, and see what's going on. Where's the occlusion? Where's the disease? I put some, for reference, I put a picture here that kind of outlines some of the arteries. Okay, so the most important part here, we have to make sure that you always have no stenosis in the common iliac. If you have stenosis in the common iliac artery, you're going to have a lot of issues. Okay, so if you follow the artery down, goes common iliac, turns into SFA. SFA gives, there's another branch for profunda, which we will discuss the importance of that. And we can see here on the right, this is the CT of the patient. I'm not sure from where you're sitting if you can see, but now we have a zoom. Okay, so we see we have a completely left occluded common iliac artery. Okay, this is a medical emergency. We need to deal with this. Okay, now let's quickly touch on SFA versus profunda. Okay, SFA, superficial femoral artery. Okay, this artery, if it becomes occluded, will cause you a lot of pain. Okay, the profunda provides collateral circulation. It keeps the leg alive. Okay, so that's the big difference, and that's the kind of question that will be on your vascular surgery board exams. Okay, so let's go to the next slide. What did we do? There was a question for Dr. Oye earlier about surgery without incision. I've done about 10 weeks of vascular surgery with Dr. Oye, so I can explain to you kind of how we approach this and what we do. And if you have any questions at the end, feel free to ask. So what we do is we take a needle, okay, a micropuncture needle. This is about gauge about 24, okay, 24 gauge micropuncture needle, and we enter. Okay, we enter here in the femoral artery. Okay, through there we pass a guide wire. Right, so we pass a guide wire through, and once that wire goes through, we begin to cannulate and dilate. And so, technically, we don't make any incisions. This is a very clean procedure, and this is basically what we wanted to do. This is the importance. So once we put the needle in, as you can see, we can do ballooning, we can do stenting. Same thing we do for if someone's having a myocardial infarction, very similar. We're just doing it in much larger arteries. So we first attempted to gain access through the femoral artery on the left, right? The left common artery. Unfortunately, we were unable to pass a guide wire. Now, why is that significant? This is the golden rule of vascular surgery. If you cannot pass a guide wire, now a guide wire is exactly what it sounds like. It's a wire. Basically that goes through the occlusion. If you cannot go through the occlusion, you cannot balloon or stent that lesion. Okay? You're going to have to either open or try a different approach. So this is what we did. We said we went into femoral. We were unable to pass the guide wire. So what do we do? What do we do? Let's go to the next slide. We went brachial, okay? We did a brachial attempt. We went there. Unfortunately, we were met with stenosis. As you can see, once we passed the dye, we couldn't do it. Now, what these scans are, you're gonna see a few of these scans. This is called fluoroscopy. Fluoroscopy is, the way you can think about it is live X-ray. So it's X-ray played kind of like a movie. So we're watching the dye once we inject it, to see where is the stenosis. So unfortunately, we were unable to gain access through the brachial, the left brachial artery. So now what do we do? Okay, let's go next slide. We went to the right. Makes sense, right? We went to the right, and there was a ton of stenosis, but we were able to pass the guide wire and gain access into the descending aorta. Okay, so now what we're doing is we are feeding the wire down, and we're trying to get through the left common iliac superiorly. So we're trying to go from the top, and we were unable to do that. And you can see that here. If you look at this fluoroscopy, the one that's on the right, you can see our wire inside is kind of curling up, and it will do that when meets, complete obstruction or occlusion. So now we're stuck. What can we do? We are going to, let's go to the next slide. Now we have to open, unfortunately. We opened up the left femoral artery. Here we gain access. You can see this is a very thick femoral artery. And on palpation, if you were to palpate this, it was full of plaque. Okay, so we performed an endarterectomy, which is, what is that? We cut the artery open and we physically removed the plaque. Okay, we tried to remove the obstruction so that we could pass a guide wire. We tried again. Unfortunately, we were unsuccessful. The next slide will show you what we pulled out. This is plaque. Okay, this is a lot of plaque. And we pulled out this much only from the left. This is all left common iliac artery. And we were still unable to put a guide wire through. So now what? So we will go to the right. We're going to try to open up the right. We go to the next slide, you'll see. Right, now we are on the right side. So we had to open up the right. At first we had no issues, but we had to open up the right, and we did an end arterectomy because there was also some minor occlusion, and we thought, you know what? Let's try to open it up and see if we can promote flow. And there was significantly better flow on the right leg. But this still does not cause it doesn't help our left leg. The left leg is suffering, ischemic, it's cold, there's no flow. What's going to happen? So now we decided interoperatively that we needed to do a femoral bypass. So the next slide will kind of show you what that looks like. So so we took a Gore-Tex graft. Okay, so what we did is we tunneled. If you look here, there's a tool, looks kind of like a hook. We tunnel basically from one femoral artery to the next. So we went from right to left. And we introduced a graft that provided collateral flow. Because we wanted to spare the leg. So this is what we did. And then once the graft was in place, as soon as we released the pressure, we felt pulses on the leg, and the leg started to change color, which is fantastic. The next slide will show you a artistic rendition of kind of what it looks like. Quite literally, a graft that goes right under the skin, yeah, just like that. And it shows we had an improvement in pulses immediately. Okay. Next slide. Okay, so let's quickly discuss, what this was important about, okay? So it's extremely important to identify limb ischemia early in the progression, okay? Because if you don't, you'll have necrosis, you'll have death, you'll have gangrene, and we know this. And it definitely, if you can pick up peripheral ischemia early, you will save your patient from amputation. We do not want to amputate, we try our best. Okay. Patients that are on vasopressors. Okay, this patient was on vasopressors for about 10 days. Please be cautious with the amount of vasopressors that we use. This patient was on about 17 of Loveth, which is incredibly high. So just be cautious in knowing that if you're treating patients with a lot of hypotension, make sure you can identify peripheral artery disease as well. There was a meta-analysis here that shows that the surgical intervention favors overall survival. Okay, so a possible amputation was averted because we were able to do this femoral bypass. Okay, and if we did do a amputation, if that was the last thing, there would be the possibility for healing would be very, very low because you need good flow to have healing. Okay, let's go to the last slide. Conclusion. Okay, great. So this case demonstrates successful management of the patient with Le-Ritre syndrome. Le-Ritre syndrome is a diagnosis made when you have complete obstruction of the aorta or bilateral common iliac artery stenosis, which is basically what happened in this case. Okay, so we want to ensure there's adequate perfusion prior to surgery to make sure the patients are off the vasopressors. And then this case report highlights the importance of attempting multiple sites when you're doing endovascular revascularization. Okay, it can definitely minimize the extent of amputation. And that's all I have for today. Any questions? Well, okay, I have a question here from our audience.
So, when we are doing thank you for your presentation. So when we are doing the procedure, like what if the vessel is ruptured?
Okay, so like a traumatic rupture of the, okay. So in that case, if you're doing endovascular and then what would happen is you will shoot your dye and you'll see the dyes everywhere. It's all over the body and you're like, okay, we have a rupture. You would get a, in a way we want to patch it. How do you patch endovascularly? We use a stent, closed stent, all right? and you try to gauge it and make sure it's the same size as the artery that you want to use the covered stent. So you'll just put that in. In this case, if we're in the iliac, we would want to use a 10 French sheet, and we'll put that in and then deploy that as quickly as possible. But be careful using the the covered stents, because once you deploy it, you will cut off any collateral branches. So you need to be very cautious when you're using it, and because you will not be able to open the patient fast enough to stop the bleeding. So you need a covered stent. Thanks.
Thank you.
Any other questions? And one more question here from West Virginia, beautiful West Virginia.
Great presentation. I just have one question. I noticed that intraoperatively, you guys decided to skip doing the fluoroscopy on the right side before opening up the left.
Yeah, we didn't need to do fluoroscopy on the right side because from the original CTA, you can see there was stenosis, so we knew there was good flow.
Okay.
So what we did, we decided we'll just go with endarterectomy and then create a graft, and that should be sufficient.
Yes, for your time to better use.
Yeah, it was unnecessary. Yeah.
We've got
Great.
a question here.
Sure.
Hi, thanks for taking my So my question is, you have a patient you said was on vasopressin for about...
Vasopressor,
Yeah, norepinephrine for about 10 days. At one
Yeah.
point that it was decided that that patient lost the pulse, and especially when the patient was a very high dose of norepinephrine. Then when did they make the decision to take the patient to have a CTA angio done? And also, if the patient has all this risk factor for atherosclerosis, diabetes, and also I believe you said the patient has a risk factor for smoking. So do you think possible it could be the smoking also that will cause
It's definitely once you have those factors, diabetes is by far the leading, uncontrolled diabetes is by far the leading cause of atherosclerosis, followed by smoking and then uncontrolled hypertension. So how this was identified, if I followed your question, you're like, when did this problem kind of arise? The patient was the one that sort of was like, my leg is in severe pain. And then once physical exam was done, we realized, hey, there's no pulses here. We need to do something about it. So then we took them down into surgery. I hope that answers your question. If I missed something, please let me know.
One more question.
Sure.
So when do you guys decided when you try the endarterectomy and then you also try to revascularize that area? When do you guys decided to finalize on doing the femoral bypass?
Okay. So when and how we decided that? Okay, so we were unable. There was no way to kind of fix the occlusion that was in the left common artery. There was no way to get through. We couldn't balloon. We couldn't stent because you have to get to the middle of the lesion. It was not possible. It was too high up. At this point, we're making an incision from the almost to the belly button. That's where your bifurcation happens. If you guys was a little taller, I could show you guys the bifurcation just under the belly button. That's where your common iliac artery starts to bifurcate. So to get all the way up there, we'd have to do a huge open procedure, and that's not what we wanted to do. So once we determined that there was multiple attempts were failed at the endovascular stenting approach, that is basically the only other option, and that includes like if you have for example, if you have a stenosis in the common, like in the aorta, we will do an aortic fem bypass, which is we will take a graft from the aorta, just underneath the inferior mesenteric artery. We'll take a graft from there, we'll pass it down through the retroperitoneal, and we will connect it to the femoral arteries. And we've done those multiple times.
Great presentation, very educative. A couple of questions. Given this situation of the patient, this must have been going on for quite a long time. Were there, besides the history of smoking, diabetes, etc., was there also a history of a walking history of the patient? Because these are the type of patients that should not have been able to walk long distances and being able to walk shorter distances, shorter. Was there?
Absolutely.
Yes.
That's definitely something that we ask in the physical exam. If you go back, the patient will complain, say, I can't walk as far as I used to, and we can initially try to deal with that medically. We will start the patient on cilostazol. Cilostazol, you can start 50 milligrams and then go up to about 100 milligrams from there, and that should help the walking. But I think our patient had progressed well past those physical symptoms.
Sure. Yes, I think another question, last question.
Sure.
Given that atherosclerosis is actually a systemic process, and you guys also are you thinking to evaluate also the coronary arteries and also the cervical arteries? These are the places where you could expect the atherosclerosis to have a lot of damage when it is in such a progressed state?
Absolutely. The CTA will give us the flow, and we didn't see that there was any occlusion. There was mild occlusion, and there were no bruits on physical exam when I examined the patient. So for the carotid artery, we didn't see there wasn't any intervention required at this time. So that's all.
Yes, I'm Dr. Edwards. I wanted to get some clarification on your procedure where you try to canalize the left common iliac artery,
yes.
And you were not successful doing that. Then you went to the right common iliac artery, and I was wondering why you did that, because there's no communication.
We went first to the brachial. We went brachial first and tried to do from superior to see if we can break through the lesion, and we were not able, because if you look at the CTA, there was mild stenosis on the right. So we wanted to make sure that we would have adequate flow before we put the graft, because if you put a graft and you don't have good flow, you'll have a Steele syndrome, and then you'll have two legs that are not working and could have complications from a Steele syndrome.
Right. Okay. So you were not trying to canalize, trying to get access to the left common iliac by going to the right. So
No. That is an approach that you can do. You can kind of go through that way, but we thought it would be better if we could come through the brachial, and that was the approach that we went with.
Okay. The other question is, since you were able to remove the
Sorry, the audio is cutting out here.
Yeah, so the question is, since you were not able, after removing the plaque in the left common iliac artery, and you saw that you were still not able to canalize that area, then you resorted to eventually do the bypass from right to left. But then wouldn't you have had, since you were not able to canalize it initially, wouldn't you have had to go much further down below that area to come up? So
No, the femoral artery was okay. We chose that site because that's the most common site for the femoral bypass.
Right.
You can do a common iliac, like a right common iliac to femoral bypass as well, but we didn't want to open the patient that far. It was a little bit easier for us to go just from femoral to femoral.
Okay, fine, thank you.
Yeah. Thank you, Cristo, for your excellent presentation. I'm just going to
Thank
ask
you, colleagues. Thank you.
About, no. I have a question. I have a question for you.
Oh, okay, Dr. Lambo.
Yes. The follow-up of the patient, you're going to do, how long are you going to do the follow-up, to follow up with the patient?
The patient was released from hospital on day 4 post-op, and they were seen 1 week after in the clinic. They're doing well, and we just continue to follow up from there.
Any complications that you have to monitor? Is there a possibility of the graft migrating, right?
Not that we didn't face any complications with this case. Sometimes you can have some issues with Steele syndromes, but that's why we tried to do the endarterectomy on the right to kind of make sure there was adequate flow to ensure that there would be less complications.
Thank you.
Thank you, Dr. Lambo.
Thank you very much, Cristo. Our next speaker is Dharav Patel. He's a third-year medical student here at Avalon. He's currently completing his clinicals in Beckley, West Virginia, and he has been a member of the research committee for the past 2 years. Prior to medical school, he received his training in kinesiology and health sciences at York University, where he was also the vice president of the Graduate Research Associations of Students in Public Health.
During his basic sciences, he completed a meta-analysis paper comparing the risk of resistance in various first-line HIV treatment drugs. His primary areas of interest have been public health and internal medicine. Today, he is presenting a case report on acute pancreatitis, which was incited by hypertriglyceridemia. Please join me in welcoming Dharav to the stage.
Thank you so much for that great introduction. So today I'm presenting an interesting case that I came across while I was in my internal medicine core here in Beckley, West Virginia. The case was encountered sometime early 2023, and I'll just wait a few minutes until the slide loads up. Okay, so here we are. So the title of the research paper today is treatment of hypertriglyceridemia-induced acute pancreatitis using heparin and insulin in a limited resource rural hospital. And the preceptor that I was working with was Dr. Zafar. Next slide, please. So just a quick disclaimer before we start off today. So the goal of our presentation today is to sort of give motivation to our basic sciences student and students who are currently starting their clinicals, and let them know that every single case that you'll come across is unique in its own way. Most common cases like acute pancreatitis can become very unique. And definitely, I hope that you take away something at the end of the presentation. Next slide, please. So a little bit of background information before I present the case. We all have studied various different causes of acute pancreatitis. Most of the students in basic sciences would remember the acronym I get PP smashed: idiopathic alcoholism, hypercalcemia, hypertriglyceridemia, mumps, and all that stuff. So one of the most common causes, which is fairly uncommon to encounter every day, is hypertriglyceridemia. It's the third most common cause of pancreatitis. Now, how do we classify hypertriglyceridemia? Sorry, just a slide before that.
Hi there.
Sorry, 2 slides before. We're still on the 3rd slide.
Are you on the correct slide, or you want to move forward or backward?
One more back, please.
One more back? Okay.
Yeah. Okay, so how do we classify hypertriglyceridemia? So the current literature identifies treatment plans based on 3 different stages of hypertriglyceridemia. So they classify mild hypertriglyceridemia, moderate, and severe. Mild is 150 milligrams per deciliter, and moderate is anything above 500, and severe is anything north of 1,000. And the treatments are based upon that. So if you encounter triglycerides over 150, it's usually just lifestyle modification, alcohol cessation, controlling other comorbidities like obesity with diet, and also providing initial treatment for LDL or providing omega-3 combination drugs. Moderate would be something like statin therapy, optimizing their glycemic index, also providing them fibrates, possibly, hopefully, high intensity statins, and also providing them niacin. Severe is where things get shaky. You can no longer give them any sorts of fats through medication or supplementation or diet, and the goal is immediate reduction of triglycerides below 1,000. And we can go to the next slide now. So the reason why we want to reduce their triglyceride levels below 1,000 immediately is because whenever you have triglycerides above 1,000, you're at a 5% risk of hypertriglyceridemia-induced pancreatitis. Not bad. Well, if you hit 2,000 or more, you have 20% risk of developing pancreatitis from hypertriglyceridemia, and over 3,000, it's in excess of 40% risk of hypertriglyceridemia-induced pancreatitis. So at that point, it's not even an if, it's just when is it going to happen? And for severe levels, like I mentioned before, your aim is to always reduce rapidly. And next slide, please. So how do you reduce a really high triglyceride level immediately? Well, we can use agents like we discussed before. We can also continue to monitor their progress with lots of nurses around the clock. And we can put a lot more burden on our healthcare system, increasing length of stays, watching our triglycerides come down slowly over 30 days in hospital, which is not realistic. And if we were at a university hospital, preferably somewhere where there's a lot of money, we can hire someone to bring us a plasmapheresis machine, which is $100,000 US for just the machine. And then we can hire staff that we have to pay who have gone on to learn about how to use this machine, a couple of extra $1,000 just for using it for one treatment. And there are also additional disposable costs that are associated towards using this machine. So $5,000 to $10,000 of use and throw material. So geographically speaking, the case that we encountered was in West Virginia. West Virginia is designated as a rural area in the United States by the United States Department of Agriculture. And West Virginia has the second lowest median income in the US. And West Virginia has the highest enrollment in government subsidized healthcare, which is Medicare, which is highest. More than 1 in 3 people living in West Virginia are relying upon the government to help them pay for their medical care. And in rural systems, resources have to be prioritized. You can't necessarily have a plasmapheresis machine take precedence over having basic things like needles, injections, all the antibiotics that you want to have on in-house. You can't prioritize it that way. And so you can't necessarily have access to a plasmapheresis machine all the time around the clock. So it wouldn't seem possible. And so at our healthcare facility, it wasn't there. And then, so if we progress further to the next slide, we are now looking at our chief complaint. So let's talk about our patient. So our patient is a 45-year-old Caucasian male that presented to the emergency department with a chief complaint of abdominal pain. Blood pressure of 170 over 100, heart rate 102, respiratory rate 19, temperature normal, O2 stat 95, still I'll take it normal, and BMI of 31, so obese. And we'll take a look at the history of presenting illness. So the patient reported to us that they started experiencing this pain suddenly in the morning. The patient described the pain as sharp and stabbing. This is exactly like a UWorld question. Rating it a constant 11 out of 10, obviously 10 out of 10. The patient pointed to their epigastric region and they reported that they were having pain that was radiating to their back. Can't get any more classic than this. The patient reported the pain is constant since it started, and the patient had also took a controlled substance at home without resolution. And the patient reported having 6 to 7 bouts of emesis throughout the day leading up to the evening. And the patient was not able to hold anything down in their abdomen, and they were nauseated throughout. And they presented to us at, I think it was 10 p.m. at night. And so the patient self-reported to us, I think I have acute pancreatitis again. And we had asked them, well, why do you say that? And they told us that this has actually happened more than 30 times before. And so the patient reported that they had this pancreatitis years ago. Their last attack was a year ago. And at that last pancreatic attack, their primary care provider had provided them with breakthrough pain medication, which was hydrocodone, the prescribed substance. And the patient also reported to us that he had a poor diet, but he had stopped drinking alcohol and does not recall his last drink in recent days, and it was several months ago. But he did recall that his HbA1c was uncontrolled for the past years and has remained around 11, 10.5 for the past few years, despite multiple different dose adjustments in their diabetes medication regimen. And then additional past medical history and surgical history remained the same throughout the ED admission. And so we'll take a look at their past medical and surgical history. And here we have the patient's past medical and surgical history. They obviously mentioned that they have had uncontrolled type 2 diabetes mellitus, recurrent pancreatitis 30 times, hyperlipidemia in the past, hypertriglyceridemia in the past, which was also treated at a university hospital with plasmapheresis, expensive stuff. And they also have hypertension, obviously, even on presentation, and they've also had prior acute coronary syndrome, and they've had myocardial infarction, which subsequently went under stenting with a drug-eluted stent. They also reported to us that they've got hepatosplenomegaly. Again, this all just fits into that metabolic syndrome picture for us. And they also had their gallbladder removed, cholecystectomy. And now let's proceed to the physical exam. Pretty self-explanatory. Nothing else in their physical exam was positive except for the things that we'll see on the next slide. So physical exam, obviously they had tenderness of palpation in their epigastric region, soft abdomen, mild rebound tenderness with guarding, and hypoactive bowel sounds. And hypoactive bowel sounds can sort of be deceiving because initially you might come in with hypoactive bowel sounds, which can change to hyper, or you can come in with hyper initially, as was present in this patient who had emesis initially, and then they have now progressed to hypoactive bowel sounds. So possibly telling us that it's progressed further. And next slide, we'll look at some of the diagnostic testing that we did. So obviously we want to get a CBC with differentials, CMP, lipid panel, lipase, CT of the abdomen pelvis with IV contrast only. Again, we don't want to give them oral gastrographin and go ahead and swallow that for us, and it would just cause more emesis. So we kept them MPO as well. UA dipstick, urinalysis, urine drug screen, just to confirm again that the control substance which they were prescribed was the only substance that they ingested. Obviously, we also want to check their bedside glucose around the clock while they're in the hospital. And we want to go ahead and do the HbA1c again, just because it's always nice to trust our patients, but we also trust our lab results a little bit more. And then we'll look at the pertinent lab findings. So what we got back from our lab. Next slide. We've got our lab findings, which show that the bedside glucose was obviously elevated, 425 milligrams per deciliter. Glucose was present in the urine, significantly 3+. Sodium, 128. Obviously, that's because they've started to urinate the glucose. They've got the glucose in the blood, and that's just diluting with the osmotic pull of water retaining in their system. And their lipase was 7,895. That's yelling at you that they've got a pancreatitis happening acutely. Bilirubin 2.2, AST, ALT elevated, and their CT scan showed us that findings were suspicious of sequelae of acute pancreatitis, correlate clinically, and they also revealed that they had the persistent splenomegaly, just as our past medical history, and they had some thickened right lower abdominal wall. And the UDS urine drug screen was positive for the same prescribed opioid that they mentioned to us. So they were not taking anything else apart from what was prescribed to them. And if we take a look at the CT now, we were supposed to see some sort of stranding just adjacent to the structures or the tissue located near the pancreas. And if we look at the next CT, we are to identify that there is a slight thickening on the right lower quadrant of the patient, and there was a thickening of the abdominal wall. And on the next slide, we are to identify that the patient has a mild splenomegaly. And further labs. The reason why I isolated these labs was because these labs took a little while to come back. So these were our lipid labs, and they showed us that the patient had triglycerides above 4,000. Now, if you remember at the beginning of this presentation, I talked about how triglycerides over 3,000 have a risk of developing acute hypertriglyceridemia-induced pancreatitis of 43%. If you're at 4,000, you've got it. There's no way around it. You've got it. And cholesterol, obviously elevated 376. LDL was elevated. VLDL elevated. HDL was below the normal range. And HbA1c was right around that 11 mark, like they mentioned to us. And so now thinking about our diagnosis. Our diagnoses were obviously they had acute pancreatitis due to hypertriglyceridemia. They had dyslipidemia present, uncontrolled diabetes mellitus, hyponatremia, and for all patients currently status post stenting, they will remain diagnosed with coronary artery disease and splenomegaly as well. And patient also had other comorbid factors such as not being compliant to their medical regimen, or at least so we thought, and obesity. So once it came time to admitting the patient into the medicine floor, my preceptor and another preceptor were in charge of admitting the patient under their service, and I was a student assigned to follow up with them during their whole course length of stay, which was 5 days. So we admitted the patient under medicine. We gave them IV hydromorphone. We also gave them ondansetron to not have any more nausea, or hopefully alleviate it. We gave them famotidine for GI prophylaxis, and we also provided the hospital protocol for the nurses to follow for insulin sliding scale. And we initially started off with a high dose and then tapered off as the patient progressed down. And another interesting thing we also provided the patient was 2 liters of O2 per nasal cannula. Now, the reason why I put a bracket there to mention this little factoid is because in the hospital settings, oftentimes you'll find that the administrators here in the US will sort of guide the way that you practice and prescribe things to your patient. One of the things that they always look out for is trying to have documentation of O2 stat below 88. I'm sure we would start O2 in all of the countries, even if the patient is 95. We'll just give them at least 1 or 2 liters of O2 per nasal cannula. But in the US, we have to have documentation of 88. So we had attached a O2 saturation monitor on our patient, and the patient walked to the washroom or the bathroom, and their O2 stat went down to 88. And so we had documentation to provide them O2 per nasal cannula. And we also gave them normal saline on our admitting orders. Just one slide before that, sorry. We gave them normal saline, which was 1 liter, and we provided them over various amount of hours, because research has now showed us that there's a controversy with regards to high volume resuscitation versus low volume resuscitations in patients with acute pancreatitis. And so we decided for a conservative figure of 200 milliliters per hour, and some research even show as low as 75 milliliters per hour. And the patient was obviously kept NPO, and a gastroenterology consult was assessed for the patient. And now we can go on over to our treatment options. So ideally, our treatment options would include double filtration plasmapheresis, which was not possible because we're a limited resource hospital. And so we decided to contact a university nearby, West Virginia University Department of Medicine, and we asked them what was their protocol in-house in place if a hospital does not have a plasmapheresis machine. And they pointed out that they currently have a monotherapy program for hypertriglyceridemia-induced pancreatitis, which included insulin drip. And the protocol was designed for patients who have approximately 1,000 milligrams per deciliter of triglycerides. And so we wanted something that was even more stronger than that. So we looked at the literature further. And we found that there was an emerging novel combination of heparin and insulin. So if we proceed to the next slide, we'd see that the dual therapy of heparin and insulin provided faster initial decline in triglycerides with dual therapy versus monotherapy. And there's a lot of publication that has gone on to explain this in the literature. So obviously our alternate plan that we formulated was insulin drip with heparin subcutaneous, D5W infusion, just so that the patient does not get hypoglycemia while we're giving them insulin. And obviously D5W would be maintained after they drop below 200 glucose. And we also gave our patient hourly blood glucose monitoring from our nursing staff, hourly vitals. We put them on telemetry, and we also gave them a Q4 BMP and Q12 lipid panel. And we kept our patient NPO initially for the 24 hours. Now, just a quick background information again, heparin and insulin dual therapy, the mechanism of action is actually well understood. All of our basic science students who attended biochemistry will tell you that insulin increases gene expression, and it also causes secretion of new or reformed lipoprotein lipase. And lipoprotein lipase is one of the enzymes involved in breaking down triglycerides. But one of the not so well-known mechanism of action of heparin is that heparin causes initial secretion of preformed lipoprotein lipase, just preformed. It does not cause release of any more lipoprotein lipase. And that's where it helps out initially. So let's take a look at the next chart. So we monitored our patients' triglycerides over the first 5 to 6 days. And we found that our patient had a initial presentation of 4,000 milligrams per deciliter triglycerides. But after the initiation of heparin and insulin at the same time, we found that by the end of second day, beginning of the third day, they had dropped down well towards and below 1,000 milligrams per deciliter. And at that point is when we continued on with the monotherapy regimen with the other protocol that we received from West Virginia University that included only giving the patient insulin drip. So we discontinued heparin for that time. And now let's look at our discharge summary. So obviously one of the things that you want to consider for patients who are around that 500, 1,000 range at discharge would be to control their glucose, like I mentioned in the background slide. So now that we have our patient in the safe window, we can control their glucose, we can control their lipids, and we can control their triglycerides, and we can control their cardiovascular disease. So these are, again, the medications that we use. So we use aspart, we use Tresiba and Jardiance for diabetes, atorvastatin, high intensity, and fenofibrates were also used. And we also provide our patient with a combination of omega-3, and we also put our patient back on their cardiovascular disease prophylactic medication, their stent medication, Brilinta, lisinopril, and aspirin, baby aspirin. And our discharge summary also included patient education. We provided them a referral for a gastroenterologist that worked very close with their PCP, primary care provider. We also gave them a cardiology referral because if a patient has had prior stenting and the patient now recently just had an episode of hypertriglyceridemia, it's very possible that they might develop some sort of process that can be sinister for their heart. So cardiology referral was warranted, and the PCP would follow up within 1 week upon discharge. And I hope that everyone sitting in the audience today can take something from the presentation. So some of the future areas of initiative that I identified for the practitioners in our audience were that hospitals need a protocol update. Every single hospital system has a protocol in place for various different common diseases, and the protocols can be used by physicians, nursing staff, allied healthcare professionals. And so if we can go ahead and implement another protocol, which includes evidence-based dual therapy protocol in place or in lieu of a plasmapheresis machine, you can save that $100,000 for something else. And if you don't have that $100,000, you can wait till you have that $100,000 and just use dual therapy until then. And you can also implement a radical approach to treating hypertriglyceridemia directly. So if you're a practitioner who was a PCP or any other physician, don't wait to initially treat the LDL and say, I'm going to first control the patient's glucose, I'm going to optimize this regimen of glucose and lipids. Just go for it. If you see triglycerides are 1,000, just go ahead and do the drip and maintain them on some heparin, bring it down to a normal range, and then retry a holistic approach with regards to medication, exercise therapy, weight loss, diet control, and also maintain a high surveillance of hypertriglyceridemia-induced pancreatitis and reduce the time of diagnosis via POCUS, point of care ultrasound. If CT is delayed, you can always substitute that in time for an ultrasound, but obviously you would need a well-trained eye to interpret the results. And future areas for initiative for our students who are in basic science or clinicals. If you haven't had a publication yet, I urge you to please approach your healthcare system and be the first student there who's going to provide them their first protocol for hypertriglyceridemia-induced pancreatitis treated with insulin and heparin. And you can have a publication on your hand for that healthcare system. Also, you can look into compiling the present publication case reports and develop a framework with regards to initiating and discontinuing the dual therapy. As you noticed, after the first 2 or 3 days, heparin has no real utility because all the lipoprotein lipase has been released. So you can further tweak the idea and add more factors that determine discontinuation and initiation of the dual therapy. And you can also propose an update to the current medical literature. You can sign up right now online to become the co-author of USMLE First Aid Step 1 and implement that. Hey, if you've got triglyceridemia, it can now be treated with insulin and a heparin, and you can have your name in that textbook too. And here are my acknowledgements. Obviously, my preceptor, Dr. Saad Zafar, Dr. Oye, and Dr. Lambo from the research department for a speedy approval for my research proposal, and WV Medicine for providing us the algorithm, and the countless nursing staff that went on to provide 24/7 documentation, care, lab, and also bearing with me, the medical student who was very naive, asking every single thing in the textbook, and the research committee and the IRB members. Thank you so much for this presentation.
So
And,
for time's sake, we were going to actually ask to hold questions until the very end, if that's all right.
Yes, that's fine.
So thank you very much, Dharav, for your insights. Next on up, we have Loveth Igburuke. Loveth is currently an MS3 and is an influencer, anatomist, and public relations officer for the Wealth Foundation for Kids in Lagos, Nigeria. She graduated with a bachelor's degree in anatomy from Babcock University, Nigeria. While there, she served as vice president of the Student Association for 2 years.
She completed her National Youth Service Corps in Nigeria, serving as a secondary school biology teacher. Loveth was also a finalist at the ACP National Level Abstract Competition in 2023, and a finalist in the Department of Research, Innovation, and International Corporation Research Symposium held in Ishan, Nigeria. Today she will be presenting her research in prognostic factors for mortality in adults hospitalized with COVID-19 in the Americas. Please give her a warm welcome.
Thank you very much. Can everyone hear me?
Yes, Loveth, we can hear you.
Okay. Good day, everyone. As introduced, I am Loveth Igburuke. I am a third-year clinical student, and today I will be delving into an important matter that's gripped the globe since its onset. So the topic for my presentation would be prognostic factors for mortality in adults hospitalized in COVID-19 infections in the Americas. Next slide. Okay. Trying to see the next, can you move to the next slide? Okay. Sorry, this was frozen for a little bit.
Is that a correct?
So,
or you want me
yes.
to go back?
Okay, yeah, can you move back to the previous slide? Okay. Because I cannot see the slides for some reason. I could see it for a brief second, but then I couldn't.
Is this the correct one?
Yes, yes.
One more back. Is this the correct one?
Yes. Yes, yes, this is the correct one. So the main message of the study for this would be, the main takeaway for our study is that in adults hospitalized with COVID-19 in the Americas, age, ethnicity, high viral load, and pulmonary comorbidities were significant predictors of disease progression to mortality. Specifically to mention, being over the age of 40 significantly increases the risk of mortality. It is an important issue that we need to investigate and understand better. So the next slide, which would be the research question. So what was our central question? Our central question was, what are the prognostic factors for mortality in adults, patients hospitalized for COVID-19 infection in the Americas? Why did we centralize the Americas? Because the US was among the countries most affected by excessive deaths from COVID-19, especially during the pandemic, and that informed our decision. So next slide, which would be the objectives. Yes, so our objectives were pretty clear. We wanted to help healthcare providers and policymakers understand these factors to aid in early intervention strategies and hopefully save lives. So we aimed at identifying the variables that progression to mortality. The goal of our study was to first systematically review studies that were involved in prognostic factors of mortality in adult patients hospitalized with this disease. And then we saw how, like, upon admission and summarize how these associations between these factors could inform mortality across populations in the Americas. Next slide. So the introduction and background of studies. So we know that COVID-19 was caused by a novel beta coronavirus SARS-CoV-2 that first appeared in Wuhan, China. It quickly escalated to a global pandemic. At that time, at the time of this systematic review, it was affecting 254 million people worldwide. I dare say that the values as at today is 692 million people worldwide, with a case of 6.9 million deaths. Next slide. Okay. So here we see that COVID-19 manifests primarily as a respiratory syndrome. We know that it could literally range from a mild like flu illness and progress to severe pneumonia. A significant study, while we're doing the literature review, exposed that at least 15% of COVID-19 patients, of the 15% of COVID-19 patients that require hospitalization, 5% of them experience a severe illness that necessitates acute care. So that is a significant number, and that informed our study as well. More current data shows COVID-19 patients, the median age for that in the US to be 48 years. The elderly was the most sensitive, and we have 70% of the elderly more likely to progress to severe or clinical illnesses. It was also very interesting to note that 5% of all the severe cases under the age of 50, only 5% developed severe symptoms, as opposed to the more than 70% likely to develop severe symptoms in the age group as the elderly. So the study wanted to determine the prognostic markers that are linked to this high risk of mortality in the elderly patients infected with this disease. We wanted to know if prognostic factors like sex, race, and other comorbidities have a major impact on in-hospital mortality, so that more trials could be designed towards this focus. Can we go to the slide on methods? Next one, search strategy. Yeah. So while we're currently expanding this study as of July 2023, for the purpose of this presentation and the conclusion of our systematic review, this search strategy was spanned from 2019 to 2021. We used the PubMed database, and we focused solely on prospective and retrospective cohort research designs. Our search terms include adults, COVID-19, prognostic factors, and mortality. Next slide. Okay, so the combination of these terms were used as both keywords and subject headings. The search was refined with filters for study design, specifically observational studies and age, specifically middle-aged and aged individuals who were 45 years old and above. Like I said, we only included aged, elder, seniors or adults, 45 years or above. Exposure had to be COVID-19 or SARS-CoV. We also have any comparison groups for that. We didn't screen for that. We also had the outcome, primary outcome was mortality. Go to the next slide. So like the filters were added for study designs to create a systematic review of the observational studies. We then retrieved the citations and exported them to an Excel sheet, and then we screened according to title and abstract first. Next slide. So I'm going to talk about briefly our inclusion criteria and our exclusion criteria and what they were for this study. So in terms of our study selection and for eligibility criteria, we included patients above 45 years of age who were clinically tested and diagnosed with COVID-19 and were hospitalized for this condition. So if they were hospitalized for anything other than this condition, they were excluded from this study. We also wanted the patient outcome was also quantified in terms of mortality, risk factors, incidence rates, person time risk, and case fatality. I would explain in a few slides why we measured our primary outcome in terms of mortality. And then the study design was observational study design. Either it was prospective or retrospective cohort study. So for the exclusion criteria, next slide. We removed patients that were hospitalized for conditions other than COVID-19 and were below the age of 45. Publications that were not in English language were also excluded. We removed review articles. Like I said, we were strictly focusing on prospective and retrospective cohort study design. So we removed studies that were not, that were review articles, case studies, reports that were not inclusive of these studies that we were based on. And the measured outcome that was not in prognosis or appropriate for quantifying acute infections as well, we also excluded based on that. Next slide. I mentioned that the mortality in the hospital, regardless of duration, however short or however long, was the primary outcome measure. And we also used case fatality rates based on the following selected prognostic factors. We had age, we had sex, race, and socioeconomic level. Now, we used the case fatality rates because the case fatality rate is best suited for acute disorders. So the case fatality rates, because COVID-19 is a short-term and classically as classified as an acute disorder, we had to use case fatality rates because it's best suited for that. The next slide, please. So for each study that we eventually chose, they were assessed and selected using the following. Like I've mentioned the fact that the diagnostic criteria of COVID-19 was based on clinical or diagnostic signs and symptoms. They had to be symptomatic. The study sample had to be described. We had to, all the COVID-19 patients were admitted following diagnosis. So also we had to make sure the prognostic factors for each of these studies were defined. So we only selected studies that had defined or predictive prognostic factors. We also had included only studies that had outcomes that were known for all or high proportions of the patients. And the primary outcome was mortality, and we used the case fatality rate as the measurement, and results was also adjusted for at least 2 confounding variables or covariants. So next slide. So we actually focused on 4 predictive factors during our investigation. The main ones, which includes the sex, the ethnicity, the pertinent comorbidities, that is the comorbidities that these patients hospitalized had maybe upon admission, prior to admission or during admission, and COVID-19 viral load within the individual. So these were the 4 predictive factors that we eventually streamlined and focused on. So we examined 2 strategies. First of all, we had to use stratification as a method of controlling variables, confounding variables. So we know that stratification is basically grouping the participants into subgroups according to the 3rd variable, so that we don't have, so that we can reduce what could be a potential confounder. And then we also, after stratification, used a new measure of association, which was multivariate analysis. So we evaluated multiple variables to identify 2 possible associations among them. So all the significant tests from the studies were 2-sided. The p-value, of course, was less than 0.5 to be considered significant. So now let's go to the results. Thank you. I'd like to bring to your attention the results of this comprehensive analysis. It was involving, at the end of the day, after excluding screening based on abstract and title, we then screened full text using our inclusion and exclusion criteria. We had 9 studies included in the final systematic review. So we had 12,895 patients. And we had 9 trials met our stringent inclusion criteria. The case fatality rate across these investigations was significant at 14.4, with fatalities consisting of 1,051 males and 841 females. Next slide. Next slide. Next slide. Okay, so this is a link to the tables. I included that for reference. I'm not sure if I'll be able to expand them, but I'm basically going to explain the results in the following slides. So we could go to the next one as well. Okay, so all the studies, surprisingly, at the end of the screening, the 9 studies that were eventually included, even though our systematic review was generally for the Americas, were all based in the United States. And the male to female sex ratio was found to be 1.4, with 4,487 cases, male cases, and 4,533 female cases reported. The case fatality for male was 25.8, significantly higher than the females, which stood at 23%. So for race, we also, in terms of, next slide, in race and ethnic diversity, we encompass various groups. The 4 primary groups that we focused on were the Black or African American, the Caucasian, the Asian, and Hispanic. The Caucasians had the greatest case fatality, which was 40.8%. This was across all studies, by the way, and across all groups. The total number of cases associated with COVID-19 in the various ethnic groups was 6,762, with 1,867 deaths and 4,892 COVID-19 survivors. So we had a case fatality rate for that as 27.6. Next. So comorbidities, this was very interesting because there's been a lot of studies really based on prognostic factors, comorbidity prognostic factors specifically. COVID-19 patients are very, very highly susceptible to underlying medical disorders as well. So most commonly hypertension, we have diabetes, HIV, and so on. So the highest case fatality was linked to COPD as the leading cause of death, and it was 35.7%. The total number of patients within this group was 5,699. With the highest case fatality rates being the patients with COPD, 35.7, and then we had 1,601 deaths, and the CFR generally was 28% for this group. So next slide, please. So the COVID-19 viral load values were also taken. So for the group that we discovered that the lower the CT value, the higher the viral load was. And actually this had the highest and the most significant results for us. This group had the highest and most significant results for us. So we had noticed that the higher the viral load, the higher the CFR that we had for that group. And that stood, I think, at least 41.8%. Go to the next slide, please. Next slide. Okay, so in summary, what did we find? The most important predictive indicator for an increased risk of in-hospital mortality was patients with high viral load. And then COPD came second, and then we had the Caucasian race as third as the ethnic group. The COPD rate was 37.5, And then we also noticed that the in-hospital case fatality for all groups together was about 14.4%. So we came to the conclusion that the predictive factors for mortality in elderly patients hospitalized with COVID-19 were especially the high viral loads, comorbidities, especially COPD, and ethnicity, race, and age. Next slide. What were the strengths of this study? This study was one of the first systematic reviews at the time that focused on prognostic factors associated with inpatient mortality in the Americas. There were a lot of studies that were focused on maybe subgroups, maybe on one particular comorbidity or maybe one particular region, but we generalized and focused on the Americas, and we also focused on a large group of prognostic factors. Also, we're using case fatality as a measure of prognosis was a better indication of disease severity. We also added to a large and diverse cohort of studies. Like I said, there have not been that many systematic reviews on COVID-19 prognostic factors at the time. So that's what was the strength of our study. Next slide. Okay. So we had constraints in literature search because this was or is still a new disease. And at the end of the day, after we had to screen, because we made sure we were very particular about the quality of the studies that we included, we ended up with just 9 papers to be considered in this study. So also the diversity of the prognostic factors that we investigated may also hinder quantitative analysis. We need more studies on prognostic factors for severe COVID-19. And a lot of the studies that we included were done before the standard treatments were developed, or dare I say, were before they became popular. So current guidelines for COVID-19 has also changed. There's also limited information because a lot of the studies focused on just host factors like age, and a lot of them didn't pay attention to underlying medical conditions. So these were some of the limitations that we faced while we were conducting this study, and even as now as we're expanding. Next slide, please. Okay, so we said COPD had the worst prognosis for patients hospitalized with COVID-19 in this research study among the comorbid group. This is linked to the active research that indicates that active smokers are at higher risk and have worse prognosis, as well as patients with COPD. Also, we had an isolated result on the higher mortality rate in Caucasian patients compared to patients of other ethnicities, because we know obviously there's things that socioeconomic status, more reporting, more hospitalizations in these subgroups may result or may contribute to this factor. So we're still working on that aspect, but that's like an isolated result. But we do have know that this knowledge is critical for like allocating health resources, and we know that based on this study, Caucasian people should be considered high-risk groups for mortality when infected with COVID-19 virus. Like I said, this is an interpretation that we're still working on. I also want to mention that in the past 2 years, there's been a lot of studies that have been able to identify the predictive factors of severe COVID-19, and majorly have pointed to old age, high sequential organ failure assessment scores. We have high procalcitonin levels. In fact, studies indicating high lactate dehydrogenase levels or high D-dimer levels associated with progression to severe disease and poorer clinical outcomes. We also have studies that have said hypoglycemia in fragile elderly patients with COVID-19 is associated with shorter survival rates. Also studies that say decreased vitamin K also reported as a poor prognostic factor in severe COVID-19. So during this, it is very important to predict severe COVID-19 prognostic factors, so it allows for efficient resource allocation. Next slide. So all studies should be considered because we need to understand the establishment, or we need to establish a link between these prognostic factors and this progression to disease mortality. There's so many unanswered questions. Next slide. There's so many unanswered questions because of, like I said, the ambiguity and heterogeneity of the data. There's so many prognostic factors. The disease is new, so little research is still done at this time. So given the diversity in results due to specimen quality, disease phase, and low discriminative power, we need further research on how to best therapeutically use all this information. Next slide. Thank you. In conclusion, I'm going to conclude now, and then make time for questions. The current study that we have done looked at predictive markers for COVID-19 in a large group, like hospitalized patients from North and South America. We decided, or we came to the conclusion that the high viral load, Caucasian ethnicity, and underlying pulmonary comorbidities such as COPD were all independent predictors for mortality in these patients. We believe that these outcomes should be given priority and more research should be conducted to discover underlying mechanisms. We need to improve our understanding and on the management of COVID-19 in vulnerable populations. Identifying these prognostic factors can and will help clinicians, policymakers, and in tailoring management strategies for patients in COVID-19 with COVID-19 infectious disease. While it could also help us researchers use these findings to develop multivariable prognostic models, and this could help in facilitating decision-making and improve, most importantly, patient outcome. I'd like to end by thanking Dr. Lambo, our research director, for all the time and effort he's put into this project so far. Also, Dr. Arja, generally to Avalon University, because we presented this at the American College of Physicians Internal Medicine Research 2023 in San Diego, as finalists, and the school was very supportive of us and is still supportive of us as we work on this research. So thank you very much.
Thank you for that informative presentation. Next up, we have Poonam Tawde.
Today, Poonam will be discussing mantle cell lymphoma, a case report of rare cavitary lesion. Please give her a warm welcome.
Hello. Hello.
Hello, Poonam. Yeah, we are pulling your presentation up, so give us a few seconds. Okay.
Okay. So good afternoon, everyone. My name is Poonam, and today I'll be discussing a unique case involving the discovery of cavity lesions following a mantle cell lymphoma, MCL. Next slide. You can play that video. Okay. So MCL is a rare and aggressive form of non-Hodgkin's lymphoma, accounting for approximately 5 to 10% of all the lymphomas. It is characterized by proliferation of uncontrolled B cells from the mantle zone of the lymph nodes. Actually, there's a video. You can just play it on the side. Despite of being a primary nodal lymphoma, MCL can manifest as external involvement in various organs, presenting a clinical challenge for accurate diagnosis and treatment. So the pulmonary involvement in MCL is relatively uncommon, and the discovery of the cavity lesions in the lung is even a rare occurrence. So the scarcity of the reported cases of MCL with cavitary lung lesions highlights the importance of further investigation into this unique clinical presentation. This case report aims to shed light on the rare finding, its underlying pathophysiology, its implication for diagnosis, treatment decisions, and patient outcomes. Next slide. Allow me to introduce you to our patient. He's a 71-year-old male who arrived at our medical clinic. So the patient's journey began with an initial presentation of unresolved pneumonia and a suspected lung mass, triggering a thorough investigation to identify the underlying cause. Upon reviewing patient's medical records, it was discovered that he had a prior history of pneumonia. Despite of receiving treatments for pneumonia, he experienced a recent episode which raised the concerns about possibility of underlying condition predisposing him to the recurrence infections. Furthermore, a significant piece of patient's medical puzzle emerged from his past, revealing a history of mantle cell lymphoma. The discovery of the previous diagnosis of MCL added a new dimension to this patient's case. Given the rarity and aggressiveness of MCL, its presence brought special attention to this lung lesion to rule out any potential pulmonary involvement from the lymphoma. The combination of unresolved pneumonia, suspected lung mass, and a history of MCL posed a diagnostic challenge, prompting the need for further investigation. Next slide. So the patient underwent both a chest X-ray and a CT scan to investigate the respiratory symptoms and suspected lung mass. The X-ray showed a progression of right upper lobe consolidation, and the CT scan showed the same severe consolidation with severe surrounding septal thickening and the cavity change, raising concerns about the nature and the extent of lung mass. Given these imaging findings, the medical team recommended antibiotic treatment and a close follow-up to monitor this patient. 2 weeks later, the patient underwent a follow-up CT and an X-ray to assess the progression of the lung abnormalities. Severe consolidation with mild surrounding septal thickening and cavity change in the right upper lobe were observed, suggesting an ongoing aggressiveness in the lung tissue involvement. A CT without contrast was conducted for pre-surgical assessment, particularly in preparation of navigational bronchoscopy. So no consolidation, pleural effusion, or pneumothorax was detected during this assessment. Next slide. So diagnostic lab findings. So in addition to the imaging, lab tests were also conducted to aid the diagnosis. The specific test that was conducted was a coccidioid screen with reflex IMDF confirmation. So this test was essential in assessing the possibility of coccidioid infection, which is a fungal infection prevalent in Arizona and can present with respiratory symptoms similar to those observed in this patient. The result for these tests showed negative findings for both coccidioids, antibody IgG, and IgM. Next slide. So now, robotic bronchoscopy and specimen analysis. A crucial robotic-assisted bronchoscopy procedure was performed to further investigate the lung mass of a 71-year-old male patient. The procedure aimed to obtain specimens in-depth analysis to determine the underlying cause of the lung mass and to rule out potential granulomas or malignancies. Under general anesthesia, the patient underwent a robotic-assisted bronchoscopy, during which needle and forceps biopsies and a bronchoalveolar lavage were conducted using the robotic platform. So the fine needle aspirate report indicated the presence of scanned bronchial cells and abnormal B lymphocytes in the right upper lobe. Additionally, the bronchoalveolar lavage also produced encouraging results with no granulomas identified. The negative test results for GMS fungus and AB acid path stain provided reassurance in ruling out certain infectious causes. Flow cytometry on the lung tissue confirmed the presence of abnormal B lymphocytes, further supporting the need of thorough investigation and close monitoring of this patient's condition. Next slide. So this case report describes a 71-year-old male patient with unresolved pneumonia and a suspected lung mass. The diagnostic journey involved a series of imaging, including chest X-rays and a CT scan, which revealed progression of right upper lobe consolidation and a cavity lesion. The presence of cavity lesions following an MCL is a rare finding and has an important clinical implications. The development of cavity lesions in the lung can occur due to various mechanisms. In this case, the presence of the cavity regions in right upper lobe raise a concern about extent and nature of the lung mass. While MCL can manifest as extranodal involvement, including pulmonary lesions, the formation of cavity lesions is relatively uncommon and warrants a thorough investigation. The robotic-assisted bronchoscopy performed was a crucial step in diagnosing the patient's condition. The collected specimen included scanned bronchial cells and abnormal B lymphocytes were sent for analysis. Although the specimen ruled out granulomas, further examination and clinical correlation with culture results are necessary to establish a definitive diagnosis. The presence of abnormal B lymphocytes raised suspicion for a possible lymphoproliferative disorder. The involvement of multidisciplinary team, including the oncologist and the pathologist, is vital in managing such complex cases. Close follow-up with repeat imaging and ongoing evaluation will help to monitor the progression of lung mass and assess the treatment response. Depending on the final diagnosis, treatment modalities such as chemotherapy, radiation therapy, and targeted therapies may be considered to address the underlying condition and optimize patient outcomes. The prognosis and the potential complications in this case depends on the underlying diagnosis. So if the lung mass is determined to be a reoccurrence of MCL, the prognosis may be influenced by the stage of the disease and patient's response to treatment. Next slide. So in conclusion, this case report highlights the importance of comprehensive diagnostic evaluation in patients with unresolved pneumonia and suspected lung mass. The identification and the characterization of the cavity lesions following mantle cell lymphoma contribute to the appropriate management and treatment planning. Collaboration among healthcare professionals is crucial for optimal patient care. Close follow-up, repeat imaging, and tailored treatment strategies may be necessary depending on the final diagnosis. By continuously monitoring the progression of the lung mass and selecting appropriate interventions, we improve the outcomes and minimize the complications for this patient with MCL. Thank you.
Thank you very much, Poonam. We appreciate your dedication to medical research.
Our next presentation is coming from clinical science students Vivian Lee and Navru Kaur. Today they will be discussing the demographics and effective strategies for improving quality of life in patients with migraines.
Please give them a warm welcome.
Yes, Vivian. Navru, you can go ahead.
Hello. Is it working? Okay. So my name is Vivian, and I have Navru with me, and there's a group of us in Arizona that came together to work on this. So our title is Demographics and Effective Strategies for Improving Quality of Life in Patients with Migraines, and it's a retrospective analysis in a family medicine practice here, where we're all rotating. Next slide, please. So our presentation is broken down into an introduction, the methods we use, the results, and a discussion and conclusion. Next slide.
With the introduction. So according to the World Health Organization, migraines is the leading cause of disability worldwide with an estimated prevalence of 14.7%. In the United States, 12% of the population experiences migraines with a higher prevalence in women than men. Family medicine practitioners play a crucial role in the management of migraines, as they are often the first point of contact reached out for help.
So for our demographics, as mentioned, we are in Arizona. So according to the Arizona Department of Health Services in 2021, the prevalence rate of migraines amongst adults over the age of 18 was 12.6. The prevalence by sex was women at 14.7 versus men at 10.6%. And prevalence by race, non-Hispanic white adults were 14.1%, Hispanic adults were 8.2%, and non-Hispanic Black adults were at 7.7%. Next slide, please.
So we wanted to see the impact of migraines on quality of life. So what we used was a PHQ, a patient health questionnaire. So what is a patient health questionnaire? It's a widely used screening tool in family practice to assess the presence of common mental health conditions such as depression, anxiety, and somatoform disorders. It can also be used to monitor and assess the treatment response outcomes. So the total score can range from 0 to 27. 0 to 4 indicates none to minimal depression. 5 to 9 indicates mild depression. We score 10 to 14. That's moderate depression. 15 to 19 is moderately to severe depression, and that's where we should actively start treating patients with symptoms. And then 20 to 27 is someone with severe depression that definitely warrants immediate treatment for depression using either pharmacological, psychotherapy, or the combination of, and also a referral to a psychiatrist or a mental health specialist. Slide.
So to add on to what Nabru was saying about PHQ and migraines, people with migraines often experience depression and or anxiety, which can impact activities of daily life. The PHQ has been valued for use in patients with migraines and can provide insight into the impact that the migraine has on each individual. And in a study by Loader et al., patients with migraines score significantly higher on the PHQ versus individuals without migraines. Next slide, please.
The slide discusses the effective strategies for improving quality of life in patients with migraines. So management of migraines requires a multimodal approach that addresses the physical, emotional, and functional aspects of the condition. Effective strategies include a combo of pharmacological and non-pharmacological interventions. Some examples of pharmacological strategies would be the use of preventative medications, abortive medications, and co-analgesics. And then the non-pharmacological strategies would be lifestyle modification, cognitive behavioral therapy.
So an interesting method that we found was patients use cutaneous vagal nerve stimulation, also known as VNS, where it's technically handheld and is held on both sides of the neck and is about 2 minutes on each side, and it stimulates the vagal nerve. And it was theorized that it could be used as a prophylactic method to decrease flares. It has been shown to inhibit cortical spreading depression, CSD, which has been implicated as a pathogenesis for migraines with aura in a study by Aida in 2010. It has also been shown to have a quicker onset of action compared to traditional methods, such as like topiramate, valproic, beta blockers, in a study by Morris in 2020. Next slide, please.
So the aim of the study was to evaluate the effectiveness of various strategies in reducing the impact of migraines on patients' quality of life. As we said earlier, it was taken from a family medicine practice in Arizona. These specific objectives are to assess whether biological sex is a risk factor for depression in migraine patients, and whether other covariates such as age, employment status, history of anxiety or depression are associated with depression in migraine patients. Next slide.
So now we're on to methods. Next slide, please. So our study design and study population, as I said, it's a retrospective of observational design where we took administrative data in the family practice that we all were at to evaluate the effectiveness and strategies for the patients that were involved in the study. And the population were those who had a diagnosis of migraines in this family practice within the period of 2015 to 2023. Next slide.
So the inclusion criteria included patient with an official diagnosis of migraines confirmed by the healthcare provider. Number 2 would be patients should have at least one record of visit at the family medicine practice during the study period. And number 3 was patient who had complete data available in the electronic medical records, including all the demographic information, the medical history, the medication use, and also the results of the PHQ scale.
So for our exclusion criteria, patients with a secondary cause of headache, such as brain tumor, vascular disorders, or subarachnoid hemorrhages that were determined by the healthcare provider were excluded. Patients who had received prophylactic treatment prior to their first visit was also excluded, and patients who had incomplete data in the EMR or electronic medical records, including like a lack of the PHQ scale, were also excluded. Next slide.
So for the data collection, it was basically extracted from electronic medical records of patients. PHQ scale was also used to measure the impact of migraines on patients' quality of life. All data were kept confidential, and only permitted study researchers had access to the patient EMR and data. SPSS software was used for all data analysis. No personal identifying information was included in the reporting of data metrics. Next slide, please.
The interventions for migraines that were evaluated in the study were education about migraine management, lifestyle modifications, preventative medication, and acute treatment options that were in the patient's record. Next slide, please.
So statistical analysis, descriptive statistics were used to summarize all the demographic characteristics of the study population. Chi-square analysis was performed as well to examine the relationship between presenting migraine history and selected characteristics of patients. Further analysis was performed to explore the association between the quality of life and selected characteristics of patients as well.
So now we're on to results. Next slide, please. So these were the selected characteristics of migraine patients that were included in this study. For the majority of participants, they were female, almost 93%. For age group, the mean was 52.36 years old and had a range of 39 years. There is one patient that was missing for the age proportion, but median was still 52.36. There's an equal distribution between employed versus unemployed, and therefore we don't see anything that correlates whether someone's employed or unemployed is affecting the results. The marital status showed that 71.4% were married, 21.4% were single, and 7.1% were divorced. Next, please.
So majority of the participants had access to health insurance. 92.9% had access to the health insurance. BMI was equally distributed. 85.7% had a chronic presenting history of migraines. So we divided the acute and chronic on basis of duration of migraines. Anyone over 3 months was considered chronic. And then for the history of smoking and alcohol use, 25% of the participants had a history of alcohol use, and then 16.6% had a history of both smoking and alcohol, while the majority, 41.6%, had negative history for smoking and alcohol use. For the family history of migraines, majority, you go back to the slide, the previous slide, please. Thank you. Majority of the participants had negative history for family, and then for the history of anxiety and depression, 64.3% had a positive history for anxiety and depression along with migraines. Next slide, please.
So within our participants, when we seen their PHQ scales, majority actually had mild depression, ranging at 57.1%, and moderate 28.6%, severe 14.3%. Medications that were used amongst our participants, there are a variety of them. Fioricet, amitriptyline, acetaminophen, Imitrex were the more frequently prescribed drugs, but other drugs like Depakote, propranolol, other over-the-counter drugs were prescribed as well, but they didn't show any superior effects compared to previous ones. Next slide, please.
So this slide shows the non-pharmacological interventions used. 46.2% of the participants were the ones that were counseled and regarding the avoidance of triggers. So in healthcare guidelines and recommendations, the practitioner mainly focused on regular patient follow-ups and adherent to the treatment. For counseling, patients were educated that migraines can be triggered by various factors, including stress, lack of sleep, certain foods like caffeine, alcohol, or processed foods. Hormonal changes in women is an important factor, and weather changes, especially since the study was done in Arizona, the heat of Arizona summers, and etc. Next slide, please.
So now we're on to discussion. Next slide, please. So again, the mean age of patients was 52.36, suggesting that the most affected group were middle-aged adults. The majority of patients were female at 93%, aligning with previous research on the higher prevalence of migraines in women. And employment status analysis revealed an equal ratio of unemployed and employed participants, highlighting that migraines can impact individuals regardless of employment status. Next slide, please.
As we discussed in the results, that health insurance, all the participants had access to it, indicating it wasn't a barrier. And then most participants had chronic migraines, emphasizing their chronic nature. So migraine is not just a headache, but is classified rather as a neurological disorder that involves the imbalance of neurotransmitters causing abnormal brain activity. The underlying mechanism make it more likely for migraines to persist over time, and thus explaining the chronicity of the migraines. Now, migraines can lead to central sensitization, a process that heightens pain perception, which means the brain becomes more sensitive to pain signals, making the migraines more intense and chronic as well. And most participants were married, recognizing the importance of potential support systems like therapy and management of other stress factors like relationships, family responsibilities, and financial concerns. Next slide, please.
So previous research suggests that family history has a predisposition to migraine, while our study showed that a higher percentage actually didn't have family history, which then can suggest that families who share the same environmental factors such as dietary habits, lifestyle choices, stress levels may also contribute to the prevalence of migraines. Pharmacological interventions such as preventative, like propranolol, and avoid medications like triptans, acetaminophen were commonly used in migraine management. Non-pharmacological interventions, including lifestyle modifications, like weight loss, change in dietary habits, avoidance of triggers, and psychological interventions such as CBT were also commonly used. Thus, this further suggests that a multimodal approach is required to help reduce the impact on these patients. Next slide, please. Okay.
So some of the strengths and limitations of the study. So I'll start with the strengths. So this study includes a thorough analysis of the various demographic factors such as age, gender, employment status, marital status, health insurance coverage, ethnicity, and BMI, as we discussed in the results. So this comprehensive approach provides a valuable insight into the diverse characteristics of the participants and allows for a more nuanced understanding of the impact migraines have on different demographic factors. Another strength of the study was the inclusion of the pharmacological and non-pharmacological interventions. This multifaceted approach reflects the better outcomes in reducing the impact of migraine on patients' quality of life. Some of the limitations this study has. So one biggest limitation of the study is the small sample size. The study reported a total of 14 participants, which may limit the generalizability of the findings to a larger population. A large sample size would provide a more representative picture of the demographics and help establish more robust associations between the larger sample sizes and the different variable analyzed. Future research with a large sample sizes would enhance the external validity of the findings. And additionally, the study relied on retrospective data collection, which may be subject to a selection bias, as participants were selected based on the demographic information, diagnosis of migraines and comorbidities. Such bias can be limited in the future with appropriate randomization. Next slide, please.
So we're on to our conclusion. Next slide, please. What we wanted our study to accomplish was to provide strategies and important insights to manage migraines and reduce the impact. So what we came up with is multimodal approaches, including pharmacological as well as non-pharmacological, shows promise in reducing the impact of migraines on patients' quality of life. And further research is needed with larger sample sizes to validate findings and optimize management strategies. Next slide, please.
So some of the main messages from our study was, number one, to prove that migraines are more common among women and adults aged 45 to 64, especially in Arizona. Number two was patients with migraine often experience depression and anxiety, impacting their quality of life. And the last and most important message being delivered from the study is that even though family medicine practitioners are the first point of reference, not a lot of people reach out. That's because there's a stigma around migraines and no one can see your pain, nausea, or sensitivity to light, sound, smell, and the symptoms are mostly hidden. So I believe that it's important to address this significant gap. Public and political awareness of migraine lag behind that of any other conditions should be our target, as our study did prove that the family medicine practitioners play a crucial role in the management of migraines and improving the quality of life. These are references. A special, next slide please. And a special thanks to Dr. Lambo for helping and supporting us with this research project.
And also thank you to Poonam as well for helping us through this. Thank you.
Thank you very much, Vivian and Nafur. Our final presentation comes from clinical science student Ella Ilshad.
Ella has a Master's of Science in Anatomy and Neurobiology from Boston University School of Medicine. She has been involved and advocating for the Syrian cause since 2011, having embarked on 5 psychosocial and medical missions to the Syrian border. Her research interests include cognitive and behavioral neuroscience.
Today, Ella will be presenting her research on the quantification of gross anatomy, learning using gaze tracking and EEG. Please welcome Ella to the stage.
Good afternoon, everyone. I wanted to thank the organizers and also thank the professors who teach us in the last hour of the day. I'm hoping that I'm able to capture your attention for the next 15 minutes or so, and hope you'll find this interesting as it applies to medical students. Awesome. So this study involves the use of eye tracking and EEG to measure short and long-term learning by medical gross anatomy students. Next slide. And as we know, the goal of medical educators is to teach their students in a manner that is effective for long-term, but also accurate knowledge retention. And in this study, we combine the use of eye tracking and EEG to measure learning. Next slide. And we ask whether these two methods are sensitive enough to indicate a physiological response when a correct identification that's made by fixating your eyes on an image is made. Next slide, please. So we devised a paradigm to investigate learning through the lens of two memorial processes of memory, familiarity and recollection. And to our knowledge, this series of studies was the first of its kind to analyze long-term learning in a classroom setting. Next slide. So what is learning? Learning is the process leading to relatively permanent behavioral change or potential behavioral change. It plays a role in the development of our perception, our language, our reasoning, our problem-solving skills. And many modern studies have shown the flexibility of the human brain when it comes to learning. So education researchers have begun seeking different research methods that are being developed across academic and scientific domains in an attempt to present the process of learning from different angles. Next slide, please. So where does eye tracking come in? It seems kind of odd that you would use eye tracking to measure a person's learning. But eye tracking monitoring has been advocated as a very powerful tool to advance the field of cognitive neuroscience, even being used in crime and forensic analyses. So viewers' eye movements can reveal memory of prior experiences without asking a viewer to give you a verbal report. And many studies show that gaze patterns differ in experts versus novice individuals. So you'd expect an expert to have a more focused gaze pattern with fewer longer fixations, and a novice to have a more scattered gaze pattern. Next slide, please. Human memory is a complex cognitive function. It's intertwined with everything that we can think of. Our thoughts, our behaviors, our interactions with the world, and the comprehensive study of memory requires an understanding of the molecular, neural, and cognitive systems with experimental models to bridge gaps between these levels. Many neuroimaging techniques have come about to be promising methods for studying learning, and EEG is just one of them. So when we're using EEG to study learning, what we're actually looking at is something called an ERP. I'm going to be referring to ERPs, or event-related potentials, quite a bit as the presentation goes on. And what an ERP is an electrical potential that's specifically time-locked to a stimulus. Next slide, please. The dual process theory of memory suggests that individuals use two mechanisms for their active memory. The first is familiarity, and the second is recollection. Familiarity is a very automatic response. It's fast acting. It's more like your gist memory. I kind of remember this. I couldn't exactly pinpoint where, but I remember having seen this before. Recollection is a slower cognitive process with more consciously accessible information. And these two processes can be dissociated at the neural level. Next slide, please. So EEG, as I mentioned before, plays an important role in learning and memory. And when we examine ERPs, or event-related potentials, what we're looking at is small voltages that are generated in response to specific stimuli. And when we analyze the results that I'll present shortly, what we're looking at is an accumulation of these stimuli, and what matters is their latency and their amplitude, and the sum of these components together produces what we call an ERP waveform. Next slide, please. So the two ERPs of interest are the one that's associated with familiarity. We refer to this as the N400 or negative 400. It's a negative deflection that's usually seen 300 to 500 milliseconds post-stimulus onset.
It's frontally based, and we also call it an early frontal effect. The ERP associated with recollection is called the LPC, or late parietal component. It's a posteriorly based signal, and it's usually seen 500 to 800 milliseconds post-stimulus onset. So if you're looking at this, yes, perfect. One back, please. So if you're looking at the image, the red is identifying where we would see familiarity in the brain, and the green and yellow would be where we would see recollection in the brain. So this study was essentially an anatomy exam. We hypothesized that students would perform more strongly on the task following the course compared to both baseline and 6 months post-course. We also hypothesized that participants' speed to answer by fixation, so by fixating on an object, would correlate with their knowledge of anatomy. And we hypothesized that the correct identification of structures in the task would elicit both that early frontal effect of familiarity as well as the late parietal component of recollection. Next slide. The study involved first-year medical students from Boston University School of Medicine. Email messages were sent to the students, and students volunteered by responding back. Accepted students were assigned a random subject number with which all their data was associated. And students were excluded if they were left-handed, if they did not have normal or corrected to normal vision, if they were non-native English speakers, and if they had previously taken a formal anatomy course. Next slide, please. All subjects also took a mental rotations test, which is a test of a person's visuospatial ability. They viewed 83 stimuli consecutively on a screen. All the stimuli were images in the form of kind of what you'd see in a practical exam, so some cadaver dissections as well as anatomy atlas images. And the task was completed at 3 time periods. Next slide, please. So session 1 was immediately before the course, then they completed their 16-week anatomy course. Session 2 was immediately following, and session 3 was 6 months later. And this is just an example of one of the images they may have seen. So if they were asked to locate the frontal bone, they would fixate on the frontal bone and then proceed to the next slide. If they did not know the answer to the question, they were asked to look to the top left corner of the screen, identifying as not knowing, and then proceed to the next slide. Next slide, please. The apparatus details of our camera and EEG are identified here. We use the gaze tracking camera from Sensomotoric Instruments out of Boston, Massachusetts, and the active 2 electrode cap for our EEG. It's a 120 electrode cap. And responses by fixation were compared to ERP signals, where we determined whether physiological activity matched the student's behavioral response, which again is them just looking at the image and fixating on it. Can I go back one slide, please? This is our apparatus. It's 128 electrodes. It takes about 30 minutes to set up, but it's quite comfortable and wasn't considered a hindrance to their performance during the task. Next slide, please. So subjects demonstrated, I'm going to get into our results here. Subjects demonstrated an improved knowledge of their anatomy at the end of the course compared to baseline, which we would expect. But subjects also retained the knowledge 6 months later. However, they took significantly longer to identify answers. Their course performance did not correlate with their speed to indicate correct answers. Next slide, please. Performance on the mental rotations test, that test of visuospatial ability, did not correlate with course performance or the speed with which students indicated correct answers. Next slide, please. So this is where things got exciting. This is a topographical map. It is averaging all of the correct responses from all of the students. And the EEG signals here, just to orient you again, you can see there's 2 ears on either side of every circle and a nose that's pointing to the top of the screen, so frontal lobe would be on the top. Here we see activity in the right parietal regions, 500 to 800 milliseconds post-stimulus onset. And this is associated with the LPC, or the late parietal component, that's associated with recollection. And again, this was an average of all and only correct responses. Next slide, please. Here we have waveforms of the relevant regions of interest. This is looking at all the correct answers from the study. Figure B on the top right is associated with the frontal effect of familiarity. The area that's boxed is 300 to 500 milliseconds post-stimulus onset, and what we have is a negative deflection, and that's what we would expect from our N400 or our familiarity response. Figures C and D on the bottom have a positive deflection, 500 to 800 milliseconds post-stimulus, and both of these are associated with our late parietal component of recollection. So these results demonstrate the time it took students to correctly answer stimuli versus their average waveform amplitudes in all of the relevant regions of interest. However, there was no significant correlation here. So overall, students retained about the same amount of information 6 months out of the course as they did immediately following the course. They took significantly longer, however, to answer task questions 6 months later. Their speed to answer did not correlate with their knowledge of anatomy, and their visuospatial ability did not correlate with their course performance. And a strong visuospatial ability also did not correlate with their speed to identify structures. Next slide, please. As far as our EEG results are concerned, our grand averaged waveform, so all those correct responses elicited a negative deflection in region of interest 1, the one that was associated with familiarity, as well as regions of interest 6 and 8, the ones associated with recollection. The positive deflection was seen, as I mentioned. However, contrary to our predictions, the speed of fixation didn't correlate with strength of amplitude signal in all of our relevant regions of interest. So in conclusion, the combined use of EEG and gaze tracking, it's a promising but challenging approach to analyzing learning. Our results do indicate that the expected ERPs do exist and are measurable in learners, given a large enough sample size. Next slide, please. So why does any of this matter? Why should we have students sit with an EEG cap on and take an exam? Yes, we were able to elicit a brainwave response when someone answered a question correctly by fixation, but how does it benefit education? So we actually built off of that initial study, and we learned that we could use the strength or the magnitude of the late parietal component at session 2, immediately following a course, and from that moment predict a person's ability to recollect something in the long term. So this can be trialed in classrooms to enhance curriculum development. The most challenging courses that are being taught can be taught using different methods. So we can take the course of anatomy, teach it flipped classroom style, team exercises, simulation, lecturing. All of those can then be tested using an EEG. And the ones that are producing the greatest late parietal component, that component of recollection, can be identified as the superior method, producing the most robust or long-lasting learning. And I think we can agree that in a world that's pushing efficiency and the whirlwind that is medicine on its own, that this could really change the way that classroom learning is structured and used for future generations. So I thank you for your attention, and I welcome any questions.
Thank you very much, Ella. So that concludes our presentations for today.
We would now like to welcome Dr. Surisha Bala to the stage for the closing address. Please join me in welcoming Dr. Bala to the stage.
Thank you so much, Justin. Today we gather here at Avalon University School of Medicine to celebrate knowledge, innovation, and pursuit of excellence in medical research. It is my great honor and privilege to deliver this vote of thanks on behalf of Avalon administration and faculty on this momentous occasion, our Research Symposium 2023. I want to take this opportunity to sincerely thank our Chancellor, Dr. Shaukat Fateh, our President, Dr. Samir Fateh, our Executive Dean, Dr. Arja, our Associate Dean of Research, Dr. Kelly, and our Chair of the Research Committee, Dr. Lambo, for providing the necessary resources and fostering an environment and encourages and celebrates our research excellence. Also, I would like to appreciate and thank your Chief IT Officer, Dr. Amin, for his support in making this event successful. I also thank my faculty as well as all the staff, as well as all the other deans for making this event possible. As Albert Einstein once said, the important thing is not to stop questioning. Curiosity is something that it has its own reason for existing. So I want to appreciate all my deepest appreciation to all the presenters who participated in this symposium, and their unwavering dedication to advancing the medical research is truly commendable. Through their tireless efforts, you have illuminated new pathways and inspired all of us to think beyond the conventional boundaries of medicine. As Benjamin Franklin once said, "Tell me I forget, teach me I may remember, but involve me, I learn." I would like to express my sincere appreciation to all the mentors who guided and supported the participants throughout their journey. Your mentorship and expertise have played a crucial role in shaping these brilliant minds and nurturing the seeds of curiosity within them. My special thanks to organizing committees, the SGA, the AMSA, and all the other volunteers who worked very hard to make this event successful. Your meticulous planning, attention to detail, and boundless enthusiasm ensured the symposium success. I also want to acknowledge the presence of all our guests and experts from various fields of medicine today who graced this occasion. Your valuable insights and feedback and encouragement was undoubtedly enriched this symposium and added the immeasurable value to the research presentations here. Of course, I cannot forget to mention the audience, our students, as well as our colleagues who took time to attend and actively engage in this symposium. Your enthusiasm, support are which fuel our passion for knowledge and research, and which we are truly fortunate to have such a vibrant Avalon community. As we conclude this research symposium, let us remember that pursuit of knowledge knows no bounds. Our work here is only the beginning, and together, as William Osler once said, that best preparation for tomorrow is doing your best today. We shall continue and push our boundaries of medical science, striving for a healthier and brighter future. Thank you once again for everybody for your unwavering dedication in maintaining this and making this symposium a resounding success. May we continue to collaborate, learn, and grow as we embark on this noble journey of advancing medicine and healthcare. Thank you so much, and happy studying, and God bless you all.
As we come to the end of our academic research symposium, we want to extend our sincere appreciation to all the speakers, presenters, and participants who have made this event a resounding success.
Your dedication to the advancing research and knowledge is commendable. Before we part ways, let us remember that the impact of this conference extends beyond these walls. The knowledge shared here today has the potential to shape the future and create positive change in our community and the world at large.
Thank you all for being a part of this incredible journey. Let's carry forward the spirit of research and collaboration until we meet again. Safe travels, and until next time. Thank you. Bye-bye.